for joining us to conduct the committee's yearly oversight of the budget requests for the Department of Health and Human Services, HHS. I'm pleased to note that this is the final committee hearing with a cabinet-level official slated for this Congress. At the beginning of the 118th, when I took the gavel, I promised to make oversight a top priority. Over this time, the committee has operated with the utmost respect and scrutiny towards every hard-earned taxpayer dollar spent by this administration. Therefore, Secretary Becerra, it is only fitting that the committee's last cabinet-level oversight hearing this Congress deals with one of the biggest department budget requests in history. For starters, this budget has an eye-popping top line of $1.84 trillion. When I saw the mandatory spending numbers of $1.7 trillion, I couldn't help but think of it as an albatross upon the necks of young Americans. I've been in Congress long enough to know that there are few things more permanent than mandatory spending. The proposed spending in this budget represents an 8% increase over the FY 2024 enacted level, which more than doubles year-over-year inflation. This unsustainable rate of spending is baked in as a function of mandatory obligations and the aging population. Today, there are more 64-year-olds than 4-year-olds in this nation. I think that's something worth repeating. Today, there are more 64-year-olds than 4-year-olds in this nation. Every day, 11,000 more reach 65, with only 10,000 children born. These statistics are an anomaly that would be foreign to any other point in American history. What's more, the American healthcare system is too expensive, complex, and inefficient for what we get. We spend nearly 18% of our GDP on health care, whereas other developed countries spend much less. Rather than investing in innovation and empowering employers to lower costs, this administration is hell-bent on shouldering employer-sponsored health plans with burdensome and costly regulations. For these reasons, $1.84 trillion isn't simply a number, it's a story. It's a demographic and fiscal catastrophe smuggled into the enormous top line of this budget. It's the legacy of older generations, and it's the inheritance of younger ones. And while unfathomable, it isn't going to hold a candle to future HHS budgets if we don't get spending in check. Furthermore, each dollar proposed in this budget represents a policy priority. Again, the burden of HHS's partisan agenda is going to fall heaviest on younger generations, which is made clear by some notable exclusions in the budget. Nowhere does the budget contain the word fentanyl, save one instance in a footnote. Fentanyl overdose is the leading cause of death for Americans 18 to 45, more than car crashes, cancer, and suicides combined. Yet the budget does nothing to address it. Nowhere does this budget mention the Biden border catastrophe that not only fuels the fentanyl epidemic, but also child trafficking. Under your watch, the Office of Refugee Resettlement transferred 85,000 unaccompanied minors to sponsors who were unable to be reached upon follow-up. These migrant children are effectively lost. Nowhere does this budget support the long-standing Hyde Amendment, one of the greatest protections for America's youngest and most vulnerable. In forcing taxpayers to fund abortions, HHS is trampling on the rights of the unborn and religious Americans. And finally, nowhere does this budget contemplate the negative effects of transgender surgeries on minors. Instead, it funds them. In 2022, HHS issued guidance stating that, quote, gender-affirming care, end quote, improves, quote, physical and mental health, end quote. Despite citing zero research or studies, the lack of scientific evidence supporting these procedures is an absolute scandal. In an ideal world, the HHS budget would represent a positive vision for a healthier country. Yours is a tax and spend monstrosity that papers over the numerous social pathologies inflicting our nation: fentanyl abuse, child trafficking, abortion on demand, and genital mutilation, to name a few. Secretary Becerra, a chasm separates Republicans and Democrats on these issues. While I don't expect to reach an agreement today on many of them, I propose we work together for the remainder of your tenure towards our shared goals. The Lower Cost, More Transparency Act, which passed the House by a wide bipartisan margin of 320 to 71, would be a great place to start. Whereas Medicare price controls are polarizing, we can find common ground in price transparency. We should also work together towards expanding telehealth benefit access to Americans, especially those in rural areas. Although I appreciate the budget calling for a ban on facility fees in telehealth, it worries me that this administration has not made it a priority to restore employers' ability to offer telehealth accepted benefits. Lastly, we can do better to coordinate the implementation of the No Surprises Act to ensure it aligns with congressional intent. While the law has successfully protected millions of patients from receiving a surprise medical bill, the tri-agency's implementation of the independent dispute resolution process has been a disaster, and I worry it will only drive up health care costs further. It's my hope that Congress and the White House can come together and craft a responsible budget for FY 2025 that addresses these concerns. As for my other concerns with the general direction of HHS, you'll get to answer for those today. With that, Secretary Becerra, I look forward to your testimony, and I yield to the ranking member for an opening statement.
Thank you, Madam Chair. Secretary Becerra, good morning. Thank you for being with us today. It's always a pleasure to welcome you back to the committee. You're familiar with this room, not only from your previous appearances before as secretary, but because you and I started our congressional careers right here in this room over 30 years ago. It's great to see you back on Capitol Hill, and I thank you for your dedication to public service. Under your leadership, the Department of Health and Human Services has made historic progress in helping workers and their families access quality, affordable care. The last Congress, congressional Democrats passed the American Rescue Plan Act. Without a single Republican vote, that law enhanced premium tax credits to lower monthly costs for low-income Americans, especially by eliminating the subsidy cliff so that more individuals could get coverage and get help getting coverage. We also passed the Inflation Reduction Act, which was enacted into law to extend the tax credit enhancements, cap the cost of insulin for people on Medicare, and for the first time ever, direct the federal government to negotiate lower prices for prescriptive drugs covered by Medicare. These decisive actions yielded positive results. For example, during the 2024 open enrollment period, a record 21.4 million Americans signed up for the Affordable Care Act coverage. That's not all. Just last week, the administration took further steps to improve access to coverage by announcing a final rule that would expand health care coverage to Dreamers. We also know that protecting our nation's health goes beyond improving access to health insurance. Recently, the department updated several regulations that will improve the lives of workers and their families. For example, the updated Section 504 regulations will protect individuals from discrimination in programs that receive federal funding through HHS. This will ensure that people with disabilities have equal access to quality care and are treated fairly in systems that are supposed to protect their health and welfare of all Americans. Additionally, the department issued a number of final regulations that support the healthcare workforce, seniors in nursing homes, and people with disabilities who rely on Medicaid. Taken together, these rules will work to improve access to and quality of health care. Unfortunately, my colleagues on the other side of the aisle frequently talk about their commitment to our nation's health and safety, but they have not backed up their words with actions. For example, my colleagues may talk about the child labor problems today. However, the reality is that Republican state legislators in many states across the country are working to reverse child worker protection laws. And despite our multiple requests for a hearing on this persistent and growing problem, the majority of this committee has yet to schedule a hearing or advance legislation to advance child labor violations. Moreover, we've seen Republicans attempt to sabotage quality health care coverage and undermine access to health care and other services that our constituents need. They restrict or criminalize a woman's access to abortion, jeopardizing the health of women, and work against the necessary care that supports the health of transgender individuals. Despite these efforts, congressional Democrats and the Biden administration will continue working to lower prescriptive drug prices, strengthen the ACA, and improve transparency for healthcare consumers. Committee Democrats remain focused on helping this administration build on our progress to expand access to care for our most vulnerable communities, lower the costs of quality care, and meet the changing healthcare needs of workers and their families. The Biden administration's proposed investments underscore your commitment to protecting the health and well-being of every American. And so, Secretary Becerra, thank you for your work and thank you for joining us today, and I look forward to the discussion. I yield back.
Thank you, Mr. Scott. Pursuant to Committee Rule 8C, all members who wish to insert written statements into the record may do so by submitting them to the committee clerk electronically in Microsoft Word format by 5 p.m., 14 days after the date of this hearing, which is May 29, 2024. And without objection, the hearing record will remain open for 14 days to allow such statements and other extraneous material referenced during the hearing to be submitted for the official hearing record. I now turn to the introduction of our witness. We have as our witness Secretary Javier Becerra from the U.S. Department of Health and Human Services, located in Washington, D.C. We thank you for being here today and look forward to your testimony. I'd like to remind the witness that we have read your written statement, which will appear in full in the hearing record. Pursuant to Committee Rule 8D and committee practice, I ask that you limit your oral presentation to a 5-minute summary of your written statement, and I'd like to remind the witness to be aware of his responsibility to provide accurate information to this committee. I now recognize Secretary Becerra.
Chairwoman Fox, Ranking Member Scott, and members of the committee, thank you for the invitation to discuss the President's 2025 budget for the Department of Health and Human Services. Let me place this 2025 budget in context. When President Biden took office in January 2021, COVID was ravaging our families and our economy. Americans were dying at the rate of 2 or 3 9/11s every day. Let me repeat that. Every day, the sum total of 2 to 3 9/11s was taking the lives of Americans in this country because of COVID. In January 2021, the number of Americans with health insurance was, like our jobs and the economy, down and on the canvas. Prescription drug prices were skyrocketing, with patients and their pocketbooks at the mercy of Big Pharma and its profits. We changed that. Today, 3 years later, nearly 700 million shots of COVID vaccines have gone into the arms of Americans. COVID is still around, but we can now manage it like the flu. Today, more than 300 million Americans, a record number, can go to the doctor or hospital and not go bankrupt because they have their own health insurance. More than 46 million of those 300 million Americans count on the Affordable Care Act for their insurance, another record. Today, while Big Pharma is still big, the president's new prescription drug law has brought down the price of insulin to $35 per month for Americans on Medicare. And as we speak, we are in negotiations with those big drug companies to lower the prices of even more prescription drugs, even as they sue us to stop us. The president's budget doubles down on the investments that made the comeback of our jobs, our economy, and our health possible. It doesn't just protect Medicare, it strengthens it beyond our lifetime. This budget lays out a vision for a nation that invests in its most vulnerable, fosters innovation, and protects every American's access to the care she needs. Perhaps most importantly, it continues our shift from a health system that treats illness to one that sustains wellness. All told, the FY 2025 budget proposes $130 billion in discretionary and $1.7 trillion in mandatory funding to advance our mission and invest in key priorities. Let me share some of those highlights. The budget provides Medicaid-like coverage to low-income individuals in the outlier states that have not expanded Medicaid under the Affordable Care Act. When that happens, another 1.5 million of our fellow Americans will secure health care coverage and the peace of mind that comes with it. This budget builds on the largest investment in behavioral health in a generation. It bolsters a 988 suicide and crisis lifeline. It gives young people support at home and in school. The president's investments in behavioral health workforce would add 12,000 new psychiatrists, psychologists, clinical social workers, marriage and family therapists, counselors, and peer support specialists at a time when their services are desperately needed. Across HHS, the budget tackles the maternal health crisis by improving access to pre- and postnatal care, supporting emergency care services, and expanding maternal care in rural and underserved communities. We are also making childcare more affordable for working families and more available where families live and work. This budget would fund more than 750,000 slots for our children in Head Start and provide universal preschool for our nation's 4 million four-year-old children, and eventually include our 3-year-olds as well. Our budget grows and strengthens our cybersecurity initiatives to ensure patient safety and privacy, and to keep our hospitals and providers, especially smaller ones, those in rural communities, running and secure. Finally, this budget further advances our preparedness efforts by investing in countermeasures to combat biological threats and antimicrobial resistant germs, by expanding our monitoring of supply chains, and by improving information sharing across federal, state, and local governments. We can't reduce the health and well-being of Americans to a line on a budget spreadsheet, but we can transform the numbers on that balance sheet into real investments and services that sustain health and promote wellness for all Americans. That's what this 2025 budget by President Biden does. I thank you for the time. I look forward to taking your questions.
Thank you, Mr. Secretary. Under Committee Rule 9, we will now question the witness under the 5-minute rule. I ask members to keep your questions succinct so the witness has time to answer. I recognize myself for 5 minutes of questioning. Mr. Secretary, this committee's efforts helped lead to the passage of the historic No Surprises Act. However, the law's independent dispute resolution process has been mired in litigation, delays, and faulty implementation. Data shows that 77% of disputes are ruled in favor of providers, and the Brookings Institute now anticipates that the IDR process will raise costs and premiums, contrary to the law's goals. What is HHS doing to improve the operations of the IDR process under No Surprises Act? And are you concerned that the law's current implementation will raise health care costs for employers and employees?
Madam Chair, thank you for the question, and you're right. Because there was a mad rush to try to make this independent dispute resolution process work, I think we saw that the gates got overcrowded, and as a result, we saw that there were delays. The arbitrators were wondering if they were going to get paid. There were a limited number of arbitrators. We think most of that has now sort of settled, We're now beginning to see that the cases that are coming through are eligible to be processed through this dispute resolution process. Initially, in that first year, we saw scores of these cases that were ineligible, and of course, they took time. And since an arbitrator only gets paid for a case that's actually adjudicated and completed, arbitrators were getting very unhappy because they were having to adjudicate claims that didn't go anywhere.
But we're very concerned about the increased costs, so what are you going to do about that?
So by having been able to essentially scrub the system so that it now is much more efficient, so that the claims that come in will have an opportunity to go before an arbitrator, we're beginning to see them run a little faster. Because the courts have given us more guidance on how they wish to see us interpret the law, it should go faster as well.
Thank you. I'm concerned by regulatory overreach by HHS over self-insured health plans. The recent Notice of Benefit and Payment Parameters Final Rule and the Section 1557 Non-Discrimination in Health Programs and Activities Final Rule saddles self-insured health plans with new Obamacare regulations. Under current law, self-funded plans are not subject to Section 1557 or regulated by the Department of Labor. Will you confirm that it is HHS policy that self-insured health plans are not subject to HHS regulation? And will you commit to abandoning any unlawful HHS efforts to regulate self-insured health plans?
Madam Chair, let me make sure I give you accurate information because we have seen an evolution there. I don't want to give you an answer that's not complete. So if it's okay, let me follow up with you to give you the precise answer.
Okay, but we'd like that answer right away. No delays, please.
I commit to giving you that.
All right. I'd like to ask about parental rights in the Head Start program. The Head Start statute goes out of its way to describe parent and family engagement in Head Start services. In the department's recent Head Start workforce proposed rule, there's even language that claims to ensure, quote, programs are consulting and engaging with current parents and families to be involved in the methods the program uses, unquote. However, the proposed rule strikes from current regulations the requirement that parental consent be obtained for mental health consultation. What is the Office of Head Start trying to hide? Does HHS intend to complete mental health consultations on children without parental consent?
Madam Chair, there's nothing that's being hidden. What we're trying to make sure we do is provide the services that are important for any child in the Head Start program. We want to make sure that whether it is ensuring the physical safety of a child or also addressing any mental health concerns. We can try to follow up with you if you have particular concerns with some of the language, but I can guarantee that what's going on in this rule on Head Start, a proposed rule, is the best interest of the child.
Well, we will see, but we think that needs to be clarified and that you are not giving mental health consultations on children without parental consent. With that, I yield and I recognize Mr. Courtney for 5 minutes.
Thank you, Madam Chairwoman. And again, Mr. Secretary, it's good to see you in the People's House, your real home in Washington. Again, I'd just like to begin my questions by noting the fact that your department and the Medicare Board of Trustees just issued its 2024 solvency report about a week ago, which was really nothing short of astonishing. In 2023, the trustees projected that Medicare would run into solvency issues in 2031. Again, a week ago, they pushed that out by 5 years to 2036. Again, that's partly because we have such a strong job market and stock market. The revenue that's coming into the program is much stronger than anyone expected. But also, the report noted that the Inflation Reduction Act is expected to lower Part B drug spending by about 9% starting in 2028. So again, you mentioned the price negotiation, which is, again, very much going to help patients. But this report suggests that this actually is going to address the question of Medicare solvency for not just seniors, but working age Americans and young people. Isn't that correct?
That's correct. The Inflation Reduction Act is working, just as you all thought it might.
So in your testimony, you noted that the 2025 budget included legislative proposals, which again would use that drug negotiation authority to even further strengthen the Medicare trust fund. Again, I think the term was that it would basically, make it solvent for the
For our
long-term
lifetimes,
future.
beyond our lifetimes.
Can you talk about that a little bit? Because I really think that is something that, for people who really question the solvency of these programs, is a really profound statement.
Yeah, it's not rocket science. You just have to be willing to invest your dollars in your savings that you incur from having better programs in healthcare back into the healthcare system. And so, as a result of what President Biden is proposing with the legislation you all passed to help us negotiate down the prices of prescription drugs, you pump that money back into the system, and guess what? Now you've guaranteed the strength of the Medicare system beyond our lifetimes.
So, Mr. Scott, along with his colleagues on the Energy and Commerce Committee and the Ways and Means Committee, introduced a measure, the Lowering Drug Costs for American Families Act, which again would take the benefits of that price negotiation and actually make it available to the rest of the country in terms of employer-based plans or individual market plans. And again, that was in the bill when we passed the measure in the House, and unfortunately didn't make it through the Senate. But again, can you sort of talk about, again, the department's perspective on this? Because really, this is about lowering drug costs for everyone.
Congressman, as you recall from the President's State of the Union address, he's right where you are, where Congressman Scott is. He would like to see the benefits that we see for Medicare recipients and lower drug costs expanded to include every American. There's no reason why only Americans who are in the Medicare program should get $35 or less insulin. Why shouldn't every American get it? And so he is very supportive of this effort to expand access to more affordable prescription drugs to all Americans.
So one other sort of ripple effect of, again, the department's work in terms of prescription drugs is that some of the drug manufacturers have almost kind of been shamed into announcing that they want to actually lower the price of insulin and inhalers, for Americans. So again, I mean, I think it's creating a virtuous sort of, environment where, again, it's encouraging and realizing that for people who sell into this market, they really, it's not sustainable to overcharge people based on their age. And again, can you talk about, again, that, again, really non-mandatory but still beneficial impact of the Inflation Reduction Act?
Well, once again, when you make it so that the drug companies have to actually negotiate on prices versus just dictate to the American people what the American people must pay, you inject a little competition, and guess what? You get to lower prices. I keep telling folks that competition is as American as apple pie. What we're doing in the prescription drug space is saying, companies, let's negotiate, get the best price, because we have a right to be competitive for the seniors on Medicare and for every American to get good prices, so we're not paying 2 or 3 times the price for medication here in the U.S. Above what others pay around the world.
As someone who suffers from seasonal allergies, I was really excited about the inhaler development. So again, thank you for your great work. And again, lowering costs for Americans. I yield back.
Gentleman yields back, and I recognize the gentleman from Pennsylvania, Mr. Thompson.
Thank you, Mr. Chairman. Mr. Secretary, it's good to see you. As you may know, I spent nearly 3 decades in healthcare as a therapist, rehabilitation services manager, and licensed nursing home administrator prior to being elected to Congress. I served patients from rural communities throughout central Pennsylvania during that time, and I learned the unique barriers these communities face in accessing quality, affordable health care. And while I appreciate your stated goals of expanding coverage and access to care that you detailed in your testimony, your agency's recently finalized rule establishing minimum staffing requirements for nursing homes seems to fly in the face of these goals. Ms. Secretary, do you believe that nursing homes across the country today have enough staff to meet their current needs?
Congressman, first, thank you for the work that you did in this space, because it's essential for so many families. There's obviously something going on within the nursing home industry where while they represent about about 1/3 of 1% of all Americans living in nursing homes, when COVID hit, we saw 20% of people dying living in nursing homes. That disparity shows that there's something going on.
Mr. Secretary, I will say that was because one of the huge contributing factors of that was bad policy by governors like my former governor, who required the readmission of nursing home residents diagnosed with COVID back into these populations. It was many of these people died as a result of bad public policy that was put forward. So, you know, I mean, but getting back to my original question, do you believe that that nursing homes across the country today have enough staff to meet their current needs? Yes or no?
I believe that too many of these long-term care facilities are not providing the staffing. In fact, the comments we received to our rule made it clear when people are talking about having 5 CNAs, certified nurse assistants, available for 55 residents. Clearly, that's not enough. When people are talking about a resident had a stroke and was on the floor for more than 15 minutes because it was breakfast time, not enough staff knew, and it wasn't until they were collecting the food trays that they discovered there was this person on the floor who had suffered from a stroke. Clearly, there are not sufficient numbers of qualified people.
Obviously, I keep close contact, obviously, having worked with older adults and specifically in many different capacities, including, I think, perhaps the only former licensed nursing home administrator between the House and the Senate. I may be wrong about that, but I think that may be accurate. It's certainly not what I've heard from nearly every provider in my district. So I would encourage you to engage with these providers more closely to learn about, you know, current conditions on the ground. Yeah, it's important for federal agencies to engage with local providers and stakeholders, and I would encourage you to do more of that, certainly in the future. According to your department's own estimates, under the proposed staffing minimums, nursing homes around the country would need to hire nearly 13,000 registered nurses and 76,000 nursing assistants. That's actually where I started my career, working as a nursing assistant as I worked my way through my undergraduate degree. Can you certify here today that not one senior across the country will lose access to care as a result of this proposal?
Carson, what I can certify is that if one single American, your loved one, my loved one, is going to go into a nursing home, we're going to try to make sure that they are provided with safe, quality care, because there will be the staff necessary to provide that care.
But in terms of access, having available facilities that are still open is an incredibly important part of that. Do you believe that nursing homes in rural areas that already face staffing shortages will be forced to close their doors or drastically reduce the number of seniors that they serve if this minimum staffing mandate takes effect?
The rule takes into consideration rural health facilities, nursing home facilities, as well as smaller nursing home facilities. We provide them with a longer transition time to adopt these new rules. We also provide them with a hardship exemption. They can show that it would be tough for them to meet the standards. They have more time. So we've listened to a lot of the facilities, and especially those in rural communities and those that are smaller.
So in terms of listening them, how do you expect nursing homes to pay for the cost of implementing this rule, which your agency estimates will cost between $1.5 billion to $6.8 billion to fully implement?
Congressman, the way I ask the question is, what kind of operation do you have now if you're saying you don't have the people you need to take quality care, to provide quality care to the people who are your residents? Because what we're simply saying is you should have a minimum level. We're not telling them they have to hire more than that. We're just saying have a minimum level so you don't have the situation as occurred in Ohio where an individual who was in a nursing home was suffering from a wound because they didn't get wound care and diaper changes and feeding. Ultimately, that wound became a bed sore. That sore then became, got to the bone and ultimately to the death.
Having worked many years in nursing homes, both as delivering that care and as an administrator, I certainly understand that, but I also understand that when you're dictating and mandating from Washington without bringing the people to the table that provide the care, what you're doing is actually creating a decrease in access to care at a time when our population is aging. Thankfully, most people age with
gentleman's
dignity
time
and
has
don't go
expired.
into a nursing home.
Gentleman's time has expired, and now recognize the gentlelady from Oregon, Ms. Matabici.
Thank you, Mr. Chair. Welcome back to the committee, Mr. Secretary. Nice to see you. Thank you for visiting Oregon. We had last year a wonderful conversation about behavioral health and the need to grow the workforce. But what I want to focus on first this morning is the roundtable conversation we had about how to address the challenges around substance use among our nation's youth. And we heard from John and Jennifer Epstein from Beaverton, Oregon, who tragically lost their son, Cal, when he took what was a fake pill that turned out to be fatal. And the Epsteins turned their grief into action, and they worked with the Beaverton School District, and they created a curriculum called Fake and Fatal to spread awareness of the danger. Compelling story. I know you heard them tell that story. The program is already saving lives. The Beaverton School District hasn't lost a student to fentanyl poisoning since they implemented the program in 2021. And with that lesson as our guide, my committee colleague, Mr. Kiley, who was just here, and I have introduced the Fentanyl Awareness for Children and Teens in Schools, or FACTS Act. It establishes a pilot program at HHS encouraging the development of partnerships between local or state educational agencies, local and state public health agencies, and nonprofit organizations to provide that necessary education, awareness, and prevention regarding the misuse of synthetic opioids. I'm grateful that the chairwoman, who's also no longer here, cares about this issue and mentioned it in her opening. I do want to clarify, however, that even though she said the fentanyl is only mentioned once in the budget, in fact, in the justification documents, for example, for CDC, it's mentioned 21 times, and for SAMHSA 22 times. So, Mr. Secretary, I know you care about this issue, so will you tell us what the department is doing to address the issue of synthetic opioid overdose in youth, and how would implementation of policies like the Bipartisan FACTS Act support your ongoing efforts?
Congresswoman, thank you. And thanks for the work that you're doing, and I appreciated the chance to visit with the Epsteins and other families who have gone through these difficult times. Maybe some folks didn't see the mention of fentanyl in the president's budget, but the president mentions fentanyl nearly 50 billion times, because that's the amount of money he's putting in his budget to address fentanyl. Most of that is going into control at the border and to make sure that fentanyl doesn't cross the border and isn't trafficked in this country. But several billions of those dollars that the president puts in his budget for fentanyl are for the Department of Health and Human Services to work with folks like those we met in Oregon who are trying to prevent people from overdosing. And so this is a priority for the president, for this administration, and we look forward to working with you on your legislation and other efforts to try to keep our Americans alive.
I appreciate that, Mr. Secretary, and I do urge the committee to bring up this bipartisan bill that Representative Kiley and I believe Representative Chavez-DeRemer as well has co-sponsored. This really important. This is going to save lives. And now I want to turn to the importance of the care economy and how federal policies can help American families. And I'll start with just a couple easy yes or no questions. Is making childcare more affordable a pro-family policy, Mr. Secretary?
Yeah, and I'm always careful when someone says it's a yes or no, but that's a pretty clear yes or no, and that's a yes.
And for fiscal year 2024, House Republicans actually proposed a cut in Head Start funding that would reduce the availability of affordable childcare for more than 51,000 children. Would that kind of cut be considered pro-family?
It would make it very difficult for us to operate.
Thank you. And also, Mr. Secretary, does President Biden's fiscal year 2025 budget increase funding for affordable childcare and high-quality early childhood education?
Dramatically.
That makes a difference, and I thank you for your leadership. I recently led more than 160 House Democrats in calling for House leadership to increase the Child Care and Development Block Grant funding to more than $12 billion. So my question, Mr. Secretary, is how will investing in affordable, accessible child care benefit not only children and families, but also businesses and the economy?
Congresswoman, perhaps the greatest benefit is that families will have the freedom to work where they want, to earn the income they need, if they know they have decent quality child care for their kids. It will also help the people who are actually providing the child care, because right now, many of these folks are leaving the child care industry because they can make more money flipping burgers at a fast food joint. We need to treat them as professionals. They're taking care of the future of this country, and we should pay them adequately so they are able to stay and make that a profession.
And Mr. Secretary, do you agree that this federal investment is necessary because there's no market solution to this? We can't just raise the tuition so we can pay the providers more. because it's already too expensive. So can you emphasize the importance of a federal investment here and what it does to the economy?
It's a federal-state partnership. We provide some of the resources, but we need the states to also chime in and do their part.
Thank you very much, and I look forward to working with you and hopefully my colleagues on both sides of the aisle about expanding access to affordable, accessible childcare. And I yield back the balance of my time.
Thank the gentlelady. Her time has expired. I now recognize myself. Secretary Becerra, welcome back. As you may recall or may not recall, last time that you were before this committee, I asked you about HHS's vetting procedures in light of reports that unaccompanied children were being placed with sponsors who were exploiting these children. At that time, you stated that you believed sponsors were properly vetted by the HHS. In February, the HHS Office of Inspector General issued a report examining whether the Office of Refugee Resettlement took steps that were required to ensure the safe release of unaccompanied children through sponsor screening and follow-up calls. One of the findings from the report stated that the case files of 16% of unaccompanied children who were released to sponsors did not contain any documentation that a required safety check on the sponsor was conducted. Mr. Secretary, ORR received referrals for nearly 119,000, at least according to our records, of unaccompanied children in the fiscal year 23. That could mean over 19,000 children were released to sponsors without proper safety checks. Yes or no, do you still stand by your statement to me last year that HHS properly vetted sponsors?
I stand by my response, but Congressman, we need to clarify. You have mixed different numbers because the report that you reference, OIG, is from 2021. And now you mentioned 2023 numbers. And what you have to remember is in 2021, in the spring of 2021, we were barely coming in. We were taking over a program that had essentially been dismantled by the previous administration. So it was difficult to have spots for these children, and it was difficult to have an operation to be able to send them to sponsors as were required by law. Things are very different from that point in 2021 today.
Then let's talk about that.
Okay.
My notebook is over there. I'd debate you a little further. But let's not quibble on that. What changes have been made as a result of this audit? And secondly, what changes have been made in regards to release of unaccompanied children to individuals who have previously sponsored children?
We have continued over those 3 years to improve the services that are provided to children. I would refer you to our foundational rule, which just became final this year, which takes a lot of those best practices. So today, for example, we have enough space for the children that are coming to us from the Department of Homeland Security. We're no longer having to use convention centers to house these kids because we didn't have the infrastructure in place. We established the infrastructure, which is the most important thing, because now they're getting the health care they need, they're getting the services they need as we prepare to send them to a vetted sponsor. Secondly, we're trying to follow up with your help in getting the resources. We're able to do not just the referral to a sponsor, but hopefully if you give us the resources, we'll be able to do follow-up. We don't have authority to do follow-up, or we're not required to, but we believe it's a good idea to do it. If you give us the resources, we'll continue to do more follow-up with these kids.
If a child who was under the care of HSS, Unaccompanied Children Program, is found to be a victim of human labor trafficking, is the sponsorship immediately terminated, and does the federal government reclaim custody of the child?
So you've touched on the issue, the difficulty. Once we find the sponsor and transfer the child to the sponsor, we no longer have jurisdiction, authority over that child. And so when you ask, will the sponsorship be terminated? We don't have the authorities to just terminate, because we don't have sight on what happens to the child once the child is in the sponsor's hand. You are welcome, and I've offered this before, Congress is welcome to give us more authority so we can follow the child.
Immediate action is taken. Immediate action is taken, though, once you find out there's a problem there.
Yes, if we're alerted, we will contact the appropriate authorities. But we don't have jurisdiction to try to stop that activity. Remember, if you're talking about a child being exploited in labor, they're already outside of our custody, because the kids that are in our custody stay in our custody. They don't go out and work.
Are there circumstances under which the child will be returned to an immediate relative of the original sponsor?
I'm sorry.
Are there circumstances under which the child will be returned to an immediate immediate relative of the original sponsor?
That is our priority, to make sure that we can place the child closest to whom they know. So a parent, if there's a parent available, an immediate relative, we seek to have them
Is
if
there
they
a
pass the
vetting process for them as well?
Yes, there is. No one gets to sponsor a child without going through a vetting process, even if they're the parents.
Well, we hope that that continues, if that's the change that's been made.
Yes.
My time has expired. I yield back. And now I recognize the gentleman from California, Mr. Decano.
Thank you, Mr. Chairman. Mr. Secretary, welcome. Thank you for being here today. I'm thrilled to see that the Department of Health and Human Services recently finalized and released its regulations under Section 1557 of the Affordable Care Act, and many thanks to you and your team for your diligent work. Mr. Secretary, can you describe what the final rule for Section 1557 does and why your department felt it was important to finalize it?
Congressman, thank you. Under Section 1557, along with the civil rights statutes, we have all an obligation to ensure that no American is discriminated against, whether it's based on race, religion, ethnic origin, and at HHS, to make sure healthcare services are provided without discrimination, we take action under our Office for Civil Rights, principally under Section 1557. We have made sure it's clear under Section 1557 that every American deserves to have protection for access to the care that they need. And we will make sure that regardless of your status as a transgender individual or an LGBTQ American, that you will have access to the care that you need.
You mentioned LGBTQ or transgender, but this addresses issues related to people, women,
Everyone.
discrimination, everyone.
Everyone.
As you know, LGBTQ Americans face severe health disparities because discrimination in healthcare facilities is rampant. There are over 3 times more, they are 3 times more likely to avoid, postpone, or skip medical care. According to a 2022 survey, 15% of LGBT individuals, 32% of transgender and non-binary individuals, and over half of intersex individuals reported experiencing some form of refusal of care by a doctor or other healthcare provider within the last year. LGBTQ people of color reported an even higher rates of refusal. How will this rule impact LGBTQ patients?
Yeah, and I should note, Congressman, it's even worse for young people who are LGBTQ. So if it's bad for adult LGBTQ Americans, it's even worse when you talk about our adolescents. And suicide rates are higher, the outcomes are worse, and we need to reach those individuals in our country. And what Section 1557 does is it shows them that there will be a protection for them. We obviously need them to report. Someone has to let us know that there are violations occurring so we can go in, stand up, and enforce any actions that discriminate against these individuals. But we made a good start in making sure the rule is much clearer about protecting all Americans.
Well, thank you. My Republican colleagues have been less concerned with the benefits of increased access to health care and more concerned about what this rule would supposedly force providers and insurance carriers to do. And I would like to ask a few clarifying questions. You may answer with just a yes or no if you feel adequate. Mr. Secretary, does this rule require doctors to perform any procedures or provide treatments that are outside the scope of their practice?
No, of course not.
Does this rule just require that providers provide the same care and services to transgender individuals that it would to other non-transgender individuals?
Right, we don't dictate what services they provide. A medical professional determines what services an individual needs, and we don't get in the way of that. We just want to make sure that if an individual needs that care, they receive it.
Well, thank you. Isn't the final rule for Section 1557 consistent with numerous court cases, including the Supreme Court decision in Bostock, and most recently a decision from the Fourth Circuit Court of Appeal that discrimination against individuals on the basis of their gender identity and sexual orientation is sex discrimination?
Yes, of course, we took into account those various decisions in rendering the rule.
Thank you. Does this rule establish a new standard of care for any condition?
It simply protects people's access to the care that they need.
Well, thank you. Mr. Secretary, we know that gender-affirming care is medically necessary care that has been endorsed by every major medical association. I ask unanimous consent to enter into the record the position statements of 30 professional medical associations in the care of transgender people. Among them are the American Academy of Pediatrics, the American Medical Association, the American Psychological Association, and the World Medical Association. Recently, we have seen unprecedented attacks on access to gender-affirming care, particularly for minors, with doctors and hospitals that treat youth facing threats of violence, and some families making the difficult choice to relocate to a different state. Mr. Secretary, I think my colleagues would agree that Americans have a right to access necessary medical care. Do you feel that parents have the right to seek evidence-based care for their children?
We should all have the right to seek evidence-based care.
Well, and Mr. Secretary, I would just like to offer another, to respond to Chairwoman Fox's concern about the lack of research surrounding gender-affirming care. I'd like to submit for the record a 19-page bibliography of research demonstrating that individualized and age-appropriate medical care for transgender people improves mental health and overall well-being. These are peer-reviewed research studies that have been published in journals such as the New England Journal of Medicine, Journal of Adolescent Health, and Pediatrics.
So ordered.
Thank you, Mr. Sarkey, for being here, and I yield back.
Okay, I guess I'll call on myself for 5 minutes. I'd like to talk a little bit about the Office of Refugee Resettlement. How many minors without parents do you know how many have been allowed in this country in the last 3 years?
Congressman, I don't have the precise number, but it's been over 100,000 over the last few years, each year.
How many each year?
Over 100,000.
Every year. So every year in this country, we let 100,000 kids in without either parent, right?
We process these children and they come to our custody because they're unaccompanied children.
Okay. Do you know how many you are keeping track of right now, or how long you keep track of? If a 14-year-old shows up at the border, how long do we keep track of them?
So to clarify the way this works, if a child crosses the border, does not have an adult supervisor, DHS, Department of Homeland Security, has 72 hours within which they must transfer that child into HHS's care because they're not equipped to handle children. We then will process the children, get all the information on the child. We then hold custody of that child as we work to find a sponsor who we vet, because by law, we're supposed to place that child in the most appropriate setting for children, and it's not in large congregate care. So we go through that process.
Percentage-wise, how many are going to another relative?
How many are going to a relative?
Yeah.
The vast majority.
Okay. Do we do DNA testing to make sure it's really a relative?
DNA testing is one of the tools we use to try to identify the individuals who are seeking to be
How
sponsored.
frequently, percentage-wise, do we do a DNA test?
It depends, because oftentimes we get some very credible information on the identity of both the child and the sponsor. And so if we need to do the confirmation, we'll go to something like DNA.
Do we know to this day where those kids are, whether they move on somewhere else? And even if it is a relative, say an uncle or whatever, do we do follow-up to see whether they're in an appropriate place?
Yeah, and as I tried to mention before, we have the records of the sponsors, and so we can reach out to the sponsors to find out about these children afterwards.
I think the New York Times once published something, and I don't quite believe their numbers, but
They're not correct.
but a large number, I will believe that tens of thousands of children out of this country, and we don't know where they are or who's taking care of them. Is that true?
So people talk about them being lost. That's all inaccurate. Remember that they are placed with a sponsor. We no longer have jurisdiction to follow up with them. We try, because we think it's important, best interest of the children, we make an effort to try to contact both the child and the sponsor 3 different times.
No. Okay, go ahead.
Yeah, 3 different times. And the number that you're citing from the New York Times is based on the fact that some of those children and sponsors don't respond to us. We don't have the authority to make them respond. They're not lost.
That's of interest, though. I guess I'm for keeping families together, okay? And I'm going to give you 2 more questions.
Yes.
Do you feel that if somebody comes here without a parent, 14-year-old or 15-year-old, why don't we at least try to turn them back to their country of origin? Is there any reason why we don't do that if a 14-year-old kid shows up? my parents aren't here, well, we're going to look for a foster parent. Why don't we send them back home where maybe their parents can take care of them?
Congressman, that may be the end result. The difficulty
Well,
is...
maybe, but why isn't it the norm?
Well, I can't say it's not the norm. What I can tell you is it takes so long to process the case of that child in immigration court that it could be 4 or 5 years before we finally decide what the status of the child will be, whether the child stays or whether the child goes back. And so it's the fact that the process takes so long that leaves this child in limbo.
I'm going to go ahead, one more question.
Yeah.
Even if, in our country, if there's a divorce or something, our court system tries to keep both parents in contact with the child.
Yes.
It bothers me that when a parent shows up with one child in this country, we can allow them in this country rather than saying, hey, wait a minute, you're here from whatever country, you're from Brazil. Why don't we wait and you see if you can come here with both parents? We're not going to take a parent and a child and leave the other parent in some other country. When we wouldn't allow that, maybe even for a parent to move to a different state. Why don't we, at least in that case, try to keep the families intact?
You have struck on the problem we have with a broken immigration system. We can't do that because everyone is entitled to a due process hearing, and because it takes forever to hold the hearing, we can't get to the point of adjudicating to what you just said. That's the difficulty when you have a broken system that doesn't let you process all these individuals, not just the kids, but the adults as well. It takes forever to finally get justice, whatever that justice might be. It may be going back to the home country.
Dr. Adams?
Thank you, Mr. Chairman. Thank you, Secretary Becerra, for testifying before the committee today, and certainly I enjoyed having you in my district. Look forward to your next visit. But let me ask you, in terms of the Office of Civil Rights, the Office of Civil Rights has opened a federal civil rights investigation into a Los Angeles hospital for its treatment of black women in labor and delivery, which follows several lawsuits filed by Charles Johnson following the death of his wife, Kira Johnson, who my bill in the Momnibus package is named for. It addresses the role that racial bias and racial disparities in maternal health outcomes have. So can you speak briefly to the OCR's work as it relates to racial discrimination in maternal health settings?
Absolutely, Congressman. And thanks for your efforts in this area, because I know that maternal health and trying to get justice when it comes to access to maternal health is something very important to you. I can't comment specifically about the case of Ms. Johnson because it right now is under investigation, but what I can tell you is that the Office for Civil Rights investigates cases of discrimination, whether race, religion, national origin, under Section 1557, which you mentioned, but also under Title VI of our civil rights laws. And so we are prepared to conduct investigations if information comes to our attention.
Okay, thank you. So the CDC estimates that approximately 700 women die each year in the U.S. from pregnancy-related complications, and we know that disparities exist among Black American, Indian, and Alaskan Native women, who are about 3 times as likely to die from pregnancy-related causes compared to white women. So given that more than 80% of pregnancy-related deaths are preventable, can you please elaborate a bit on how the budget invests in improving maternal health outcomes across the country?
Absolutely, Congresswoman. The president's budget, if you look at it closely, invests close to $400 million to try to address this issue of maternal mortality and morbidity. As you know, we have engaged in numerous efforts over these last 3 years to try to attack this problem. You're likely aware of the fact that under the Medicaid program today, we have instituted, and with your help, instituted a program where instead of offering only 60 days of postpartum care to a woman in Medicaid and for herself, for her child, today that a state is able to offer 365 days of postpartum care to that woman and her child. That now has been taken up by 45 of our 50 states who have that program. The interesting thing about that is there's still 5 states that haven't seen it fit to offer to their women and children in their state access to healthcare services when they could.
Yeah, we need to work on that. But according to KFF, that study, it compared white women to the women of color have higher pregnancy-related mortality rates, are more likely to live in states with abortion bans and restrictions, have higher uninsurance rates, and face greater financial barriers to seeking out-of-state abortions. And these findings suggest that Dobbs widened the existing stark racial disparities in mental health while also putting Black women especially at risk for further criminalization. So what steps has HHS taken to combat widening racial disparities in maternal health being exacerbated at the state level by abortion bans?
And Congressman, I think we should note that in these states that now restrict access to the care that a woman needs for reproductive services, the growing number of women who are going to be impacted most are women of color, because typically they're the ones that have the lowest income. They're the ones that have least opportunity to access the care they need in another state because they don't have the resources or the capability to leave the state. They may have commitments and so forth. So it becomes very difficult in these states for women, period, but for women of color, it's desperation. What are we doing? I mentioned some of the work that we're doing to make sure that all women have access to the care that they need. Even in these states that are restricting access to reproductive health care services, the Medicaid program that offers care for a woman and her baby, postpartum care for 365 days, is available. The close to $400 million that will be there for maternal mortality, morbidity work is going to be available to all those states. We're doing what we can. We just instituted a rule that will protect the privacy of that woman's health care needs and privacy of her physician and providers, so that they can feel comfortable engaging in conversations about the reproductive health services a woman needs.
Thank you, Mr. Secretary, and again, thank you for all of your incredible work. We appreciate it, and you're welcome to come back to my district anytime.
Thank you.
Mr. Chairman, I yield back. My time's up.
Yes, ma'am. The time has expired. Mr. Allen, you're recognized for 5 minutes.
Thank you, Madam Chairman, and thank you, Mr. Secretary, for being with us today. Now that the federal government owns and is running health care, we're encountering disastrous problems throughout the country. We're losing providers because of the oppressive policies of HHS and CMS. Patients are compromised by complicated rules requiring prior approvals and limits on care and rehabilitation. It's not free market and it's not free patients. It's all governed by this branch of the government. We're spending $4 trillion in this country on health care, $1.6 trillion of taxpayer dollars on health care in this country. When Medicare became law, 3 people were paying for each one Medicare recipient. Today, 1 American is paying for every 3 Medicare recipients. We've had some difficult policy made in the last 80 years in healthcare, and it's a runaway train. I've asked you this question every time you've come to this, and I served on the Healthy Future Task Force, and I couldn't get an answer there either. But, I keep asking, where are all the dollars going? Who is getting them? Is it the federal agencies? The providers, their incomes are decreasing, as I understand it. Practices, hospitals are consolidating because of this problem, creating a problem everywhere. And I've asked you that question. Have y'all figured it out over there? Can you give me a breakdown of where every federal and paid dollar goes for health care?
Well, here's the interesting thing, Congressman. I can tell you where the federal dollars go because we keep an accounting of it. I can't tell you where the private sector dollar goes. You mentioned prior authorization. That has nothing to do with the federal government. Prior authorization is something that the insurance companies came up with to try to keep providers from being able to offer the services that they believe are necessary. We can't get in that space because that's done by a private entity, that private business. I would tell you that the answer to your question, where are those dollars going? It's the middlemen. We've heard about all the money that's going into the PBMs. The PBMs are the ones that are essentially the go-betweens between pharmaceutical companies and the pharmacies. and the dispensing. In between the pharmaceutical companies and the pharmacies, a whole bunch of money
Not to cut
is in
you
that
off, and
system.
I've got limited time here, but realize the insurance companies are basically in bed with the federal government. I mean, the federal government is
I
running
never see them in
healthcare
next
this
to my
country.
pillow, I'll tell you that.
Democrats passed a partisan bloated Inflation Reduction Act, and the drug price setting provisions in this bill make developing treatments even more difficult by not allowing the cost of the development to be recouped, especially for small molecule products. Due to these differing timelines, there's concern in the medical community that the law does not provide enough time for small molecule manufacturers to recoup research and development costs. Could you tell me yes or no, will HHS address the differing timelines between small and large molecule drugs to ensure it does not increase the cost of drugs for patients and does not disincentivize the innovation of drugs in the future?
If you're speaking about the negotiation program that we're engaged in with drug companies, we cannot seek to negotiate the prices of some of those drugs that you just mentioned until they've been on the market for many, many years. And
So yes, you are.
So we have taken that into account.
Okay.
Innovation, we take into account what
right.
they charge, or what they say they invest in research and development in
Okay.
any price negotiation. So
All right. Yes is what I needed to hear. Back in February, the National Association of Attorneys General sent a letter to congressional leaders on behalf of a bipartisan group of 39 attorneys generals, including Georgia's AG Chris Carr, urging action on pharmacy benefit manager practices. This letter outlines several PBM practices, such as spread pricing, tying their own compensation to the list price of medicine that are increasing cost of millions of patients, employers, and community pharmacies, not only in my state, but across the country. Since you've mentioned on record that HHS is currently enforcing the drug price transparency rule, I'm assuming that you also agree something needs to be done to protect patients and stakeholders from such practices.
as I mentioned, PBMs, we would all like to do more.
That would be a yes?
We would all like to see you do more when it comes to PBMs.
Okay, I have a few more questions. I'll submit those for the record. I'm out of time, and I'll yield back. Thank you.
Thank you, Mr. Allen. Ms. Jayapal, you're recognized for 5 minutes.
Thank you, Madam Chair. Secretary Becerra, it's good to see you. Congratulations on the important work that President Biden and your department have done to lower prescription drug prices, to improve transparency for patients, and to bring the number of Americans without health insurance down to historic lows. This is very, very important work. And of course, you know that despite these historic lows, there are still 25 million people who are uninsured in America. And on top of that, many Americans are still underinsured, meaning that even if you have insurance of some kind, you simply can't afford health care. The premium tax credits that we included in the Inflation Reduction Act serve as a very important patch for our broken for-profit healthcare system to immediately lower costs for Americans. But as you know, my belief is that we're only going to have full accessibility when we transition to a single-payer Medicare for All, improved Medicare for All model. Medical providers are steering patients towards bank loans and credit cards that saddle them with interest on top of their medical debt. It's really unimaginable that in the richest country in the world, 23 million Americans owe $220 billion in medical debt, the majority of whom owe over $10,000 in debt, which just continues to accumulate interest. And meanwhile, we have private insurance companies that are doing everything they can to continue to raise premiums and lower care, and part of that is an increasingly public effort to privatize Medicare. As you know, I'm the proud lead sponsor of Improved Medicare for All because I believe it's time to make sure that our healthcare system prioritizes people over profits. A recent Congressional Budget Office study estimates that transitioning to a Medicare for All system would actually save $650 billion per year in costs. And so I'm going to continue to work on that. But in the meantime, I want to discuss what can be done right now to improve healthcare for all Americans and prevent wasteful subsidies to corporate insurers that offer what I call Medicare disadvantage plans. It's estimated that the federal government will overpay Medicare disadvantage companies approximately $83 billion in 2024 alone. $83 billion. That's at least 4 times as much money as we would need to expand traditional Medicare to cover dental, hearing, and vision benefits. A report from the Committee for a Responsible Budget showed that over the next decade, these overpayments will increase the national debt by at least 2% of GDP and advance Medicare Trust Fund insolvency by 3 years. And so I want to thank you particularly for your very strong 2025 Medicare disadvantage rate notice that your department put out in April, as it takes key steps to curb these drastic overpayments. How can Congress continue to partner with your department to go further in curbing overpayments?
Congresswoman, thanks for all the work you've done on this, and I'd say that probably the most important thing you can do help us with is transparency. We need to get behind the curtain of these insurance companies to find out how they're operating, because as you mentioned, they're getting paid more than the traditional fee-for-service Medicare. We want to see how they're spending the money, because in some cases they're saying they don't have enough and they're going to have to start cutting services. And it's not Medicare that would be cutting, it would be the insurance companies.
Not only are the plans exorbitantly costly, but without that kind of meaningful oversight that you're talking about with bad actors, these plans actually have negative health impacts on Americans. An analysis from the National Bureau of Economic Research found that if CMS canceled contracts with the worst performing 5% of MA plans, it would save 10,000 plus lives per year. Can you tell me what resources your department needs to strengthen enforcement mechanisms and how strong oversight of these plans can actually promote health equity and health care for people across the country?
I probably need 5 minutes to give you the full answer, because as you know, the Centers for Medicare and Medicaid Services has been underfunded for more than a decade when it comes to its budget, even though it has been asked to do the lion's share of work at HHS when it comes to Medicare and Medicaid. If we had an agency that was fully resourced, we could certainly be more aggressive in trying to do the work to get behind that curtain that I mentioned, so we could see exactly how taxpayer dollars are being spent by all these recipients of these dollars, the insurance companies and so forth.
I really appreciate your work on this, and I have to tell you that and I've said this to you separately outside of the hearing, I'm hearing from constituents every day who are getting pulled into these Medicare disadvantage plans, promised a whole bunch of stuff that they don't get, and ultimately then end up trying to get off of them, which is extremely difficult in many cases, and get back on traditional Medicare. I think we need to continue to improve traditional Medicare and make sure that we provide health care for all Americans. Thank you for your work.
Thank you. Mr. Banks, you're recognized for 5 minutes.
Mr. Secretary, the number of children who have come across our southern border on your watch and Joe Biden's watch is estimated at 481,535. Last year alone, it was 137,000. And if you compare that to the last year of President Trump's term, on his watch in the last year of his term, it was less than 25,000. So a pretty significant and dramatic increase of unaccompanied children coming across the southern border. The New York Times says that your department has lost contact with 85,000 minors, and that statistic is over a year old, so undoubtedly it has risen in the past year. Congressional Research Service says that 75 to 80% of unaccompanied children are now traveling with smugglers, and those smugglers have reportedly sold migrants into situations of forced labor or prostitution, forms of human trafficking, in order to recover their cost. The Coalition Against Trafficking in Women says that 60% of unaccompanied children caught by cartels and are exploited through child pornography and drug trafficking. And the New York Times has reported that almost 1 in 3 migrant women, including a large population of young girls, are reported to be sexually assaulted, over 1 in 3 of them who are coming across our southern border. Mr. Secretary, is it the policy of this administration to return children, unaccompanied children coming across the southern border back to their families where they came from, or is it to send them into the United States away from their families instead?
Congressman, let me address that question as it pertains to the Department of Health and Human Services, because we don't engage in immigration activities. We accept the children that the Department of Homeland Security has encountered.
Is it the policy of the Biden administration to return children back to their families or to send them into the United States to sponsors or to someone else, never to be seen from again? What's the policy?
The administration policy, and I'll try to speak for it generally, because again, it goes beyond my jurisdiction, but generally the policy is to abide by what the law says we must do. When someone requests an asylum hearing, by law, they're entitled to an asylum hearing. So
let me ask this a different way. If a 15-year-old girl came across the border from, say, Guatemala, would we send her back to her family in Guatemala, or would we keep her in the United States?
if she requested an asylum hearing, we would by law be required to offer her a hearing.
How many children have we returned back to their families in the country they came from on
Again,
your watch?
That would not be something I have information on because I, at Health and Human Services,
Thousands,
we don't do
hundreds? Can you estimate?
I'm not going to speculate, but that's something that you can ask the Department of Homeland
You and I
Security.
both know the answer to that is zero. Zero children that you've returned back to the country. Let me ask you this. Hypothetically, if you and I have something in common, we both have girls. If my daughter or your daughter was smuggled to Guatemala, would we expect Guatemala to return our daughters back to us, our families in the United States of America, or would we expect them to keep them in Guatemala?
Again, you're asking me to speculate, but I will tell you, I would do anything I have to do to get my daughters back.
Yeah. So why isn't the Biden administration doing that?
Because we have to respect what the law says, and the law says you have to provide someone with an adjudication of their claim for asylum.
Well, the law says that because Joe Biden has made that the law.
No,
one of
that's
his
not true.
first acts as president
Congressman,
was to
that's inaccurate. That
exempt
law has-
unaccompanied minors under Title 42. He did that. You did that. You're responsible for that law, and you've never. By the way, have you ever come to this committee and asked us to change that law? Do you support changing that law to allow us to send those children back to their families in the country they came from?
The president has asked you all to change the law. There was a bipartisan bill to change the law.
I think I've only got a little bit of time left. I think the reason that you're doing this, Mr. Secretary, and your boss, Joe Biden, is because Democrats are getting rich off of it. The Global Refuge CEO, an NGO that you funnel a lot of money to, her salary is $520,000, and it doubled over 3 years. The former CEO of an NGO called Southwest Key Programs made $3.5 million. The new CEO makes $1 million. The CEO of Endeavors, who was an Obama administration aide, made $600,000 in 2022. A former Biden transition official who helped you vet political appointees helped Endeavors secure a $520 billion no-bid contract. These groups are making hundreds of millions of dollars, and now you are asking us to give you $9.3 billion to funnel to more of these NGOs so that your Democrat friends and donors can get even more rich. I think that's shameful, it's sickening, and I'm going to do everything I can to fight against it. Madam Chair, I yield back.
The gentleman's time's expired. Ms. Wild, you're recognized for 5 minutes.
Thank you, Madam Chair. Secretary Becerra, good to see you again. When you were in my district not too long ago, we briefly discussed mental health issues, and I want to return to that. In recognition of May as Mental Health Awareness Month, I'd like to discuss what the department is doing to address the very real mental health crisis that it continues to affect so many Americans. And at the very top of that list, my concern has to do with kids and online safety, and their health or the harmful impact. And according to CDC data, children between the ages of 8 to 12 spend an average of more than 5 hours a day on their screens, while teenagers log over 8 hours every day on their devices. I'm not entirely sure whether that includes school, interactive time online or not, but either way, that's a lot of hours. And I'm a really proud supporter of the Bipartisan Kids Online Safety Act, which would require social media platforms to protect minors from specific online harms, like promoting eating disorders, substance abuse, suicide, sexual exploitation. And I know the Surgeon General has indicated that he will prioritize the mental health of children, as tech companies, quite frankly, massively profit through traffic generated by young users. First, can I assume that you agree with the Surgeon General's assessment that children are vulnerable and at risk?
No doubt our children are vulnerable.
And can you describe for us what your department has done along the lines of protecting kids from the harms of social media, particularly with regard to mental health issues?
So, Congresswoman, we have tried to provide support where we can. Most of the areas where we have jurisdiction relate to providing services, treatment. And so, for example, standing up the nationwide 988 suicide and crisis lifeline, so that kids who are experiencing real challenges, mental health challenges, for example, know where they can go. We have provided behavioral services in the schools, and we're doing more and more of actually providing, through Medicaid, behavioral health services in the schools so we can approach a child while they're in school. We're doing more of that. But what we don't have is we don't have the authorities or jurisdiction to try to regulate the social media industry.
The content, and I understand that. That's why I was trying to ask my question in such a way that it was focused on, and I understand you pretty much have to deal with their health situation without being able to address the root cause, because that's not under your jurisdiction. But you mentioned suicide, and one of the things I'm terribly concerned about is that in Pennsylvania, suicide is the third leading cause of death for children and young adults aged 10 to 25, which is, to me, just unfathomable. We created the 988 Suicide and Crisis Lifeline, which I was a proud supporter of, very happy about that. But how does your budget for 2025 support the continued improvement of these kinds of services?
This president has invested more money in behavioral health than any previous president. And his budget continues that increase in services and support. We believe it's important. When 9 in 10 Americans are telling you that America is experiencing a mental health crisis, you got to do something. It's really impacting our children. You've mentioned the issue of social media. We know we have to be there. We're trying to work with our states. The more resources you give us, the more we can help our states.
Yeah. Well, I hear you on that. And one of the things I will say, you mentioned behavioral health in schools. Every school superintendent I talk to, and I've talked to many in my district, their number one flag for me is that they need more trained and educated therapists, counselors, that kind of thing. Many of our schools, elementary schools, one counselor is shared among 5 or 6 schools, which of course doesn't allow them to get to know the children at all. So I'm glad that your budget is focused on that and that the president is focused on that. And I want to make sure that that the states know exactly what they need to do to access the help they need. And in the last 20 seconds here, is there anything in particular you would highlight for the states?
I believe the number is now somewhere around 15 states that have taken up the challenge that we put before them to increase Medicaid services in the schools for behavioral health. Not every state is doing this. They have to submit a waiver authority so they can do this. But rather than have to find that your child in your class is having troubles and send them off to the principal and say they need to be referred to some physician, you have the behavioral health specialist right there in the school, and you can do it immediately.
Thank you very much for your focus on mental health. With that, I yield back, Madam Chairwoman.
Thank you. Mr. Owens, you're recognized for 5 minutes.
Thank you. Mr. Secretary, I hadn't planned on going this direction, but I can't help it at this point. We just had one of my colleagues talk about some of the evil that's happening at our border. There's no longer a rapid DNA test as of June of 2023 because of the Biden administration, which means we can no longer tie children coming across the border with the people bringing them across the border. There's reports of 85,000 children being lost. So far, the best you can give us is that they're not lost, it's just the people are not answering the phone. We're now hearing about children being used and reused, going back and forth to the border because of the cartel. We're talking about slavery, rape, abuse of children, stealing of children. You say that if this was your child, you'd do everything they could to stop it. What about other people's children? How can you remain part of an administration that allows this evil to happen? We talk about it, we're going to take lunch in a little bit, we move on, and nobody thinks about it other than the folks that are being impacted. These parents, that the children being stolen, they can't just give it up the way it seems like the my administration is doing. Let me just say this, because it appears that there's a big hit on private market. Let me tell you what happened to this in the private market. A private company did the same thing, they'd be shut down after losing the first 10 kids. And then those who would be responsible for it, we'll find them in orange suits, paying a price for decades because of losing 85,000 children. So I think it's disgusting, to be honest with you. We're not in the 1800s, slave trading. We're not in the 1930s, where we're allowed the Nazis to do the same thing with the Jews. We are seeing this real time. We're sitting here talking about the lives of children, adults, and yet there seems to be no concern about resolving it. Let me do this. I need to say that I've heard your answer, so I know right now that's not on the top of your agenda. There's a plethora of rules coming through our administration, this administration. A new rule called the Non-Discrimination in Health Programs and Activities is an example of one of the rules that HHA members are now have put together. I'm curious, who on your team is responsible for putting together and deciding on these rules? Do you have a team of group of people that do this, that say this is what we're going to do now for this particular industry?
We have a very large team because we have a number of agencies. We have CMS, we have NIH,
Okay,
we have
but
FDA.
within those agencies, there has to be somebody. Do you have a small team? There has to be somebody making these rules.
That's correct.
All right, so who are they? Is it possible to get names of these bureaucrats that are changing literally the industries that we see across the board?
I'm not sure I understand. Congressman, that all goes through a public comment period. Everybody sees what we're doing.
Well, I'm sorry?
There's no rule that becomes final that hasn't gone through a public comment where you and everyone
Well,
else
you go
has a
through
chance
that
to take a look
process,
at it.
but there's somebody that comes up with the rules. We're talking
But
about right
before
now.
that rule becomes final, you get to see it. Everyone gets to see it.
I'm not talking about what goes through the process. Who makes up these rules? Who is it sitting at the table? Or you have physicians that are sitting at the table when it comes down to that's going to be impacting physicians?
Yes.
Okay, so this rule you have here, the Non-Discrimination in Health Program. From what I understand, by the way, physicians do have the religious liberties, right? They still have that opportunity to be able to act based on their religious conscience.
Everyone does.
Okay, so the Non-Discrimination in Health Program, would that require doctors to provide gender-affirming care regardless of their religious beliefs?
No one is forced to do anything that goes beyond their.
So even though it's a
religious
rule, they are not forced to do this in their situation, in their industries.
The rule does not force any physician to do something that's against their religious beliefs.
Okay. Well, I was told differently, but we'll make sure we follow up on that one.
Yeah.
If in case.
Go ahead and
all right.
correct
So
them.
I guess in this case here, then the rules really are not rules. It's not just a suggestion.
No, these are rules. These
Okay.
are.
All right. So if it's a rule, are you saying then that they can decide not to just do whatever the rule might say then?
If it goes against their religious beliefs, under the law, they have protections for their religious beliefs. Therefore, they would not be forced to do something that goes against their religious beliefs.
Okay. All right. Well, I'm glad to hear that. I was told a little differently. Let's just wrap up then. I just have a few seconds. We're going to make sure I think American people hold this administration accountable for what's happening at the border. 85,000 lives, innocent children, is not acceptable in this country. No longer. And the fact that you're in a position, in the administration, you should have some sway to make sure those that are part of this process are making changes. So,
Congressman, if I could just, in 5 seconds, just respond. Yes. If 85,000 children were lost, you, me, everyone in this room would have taken action. That number is inaccurate. That's not a statistic that's real.
So what is the real number? How many have been lost?
That's the thing. They're not lost. They're
They just not answer the phone. In other words, the sponsors not answer the phone.
Well, Congress did not give anyone in the federal
let me
government the authority.
just say this. When you leave it, you give it to a sponsor, they do not answer the phone, you don't know where those kids are, they are lost. Let's just if you don't know where they are, you don't have their address, you can't go and pick them up, you can't look, do a welfare, they are lost.
Accurate.
Okay, with that, I want to yield
accurate.
back my time. Thank you.
Yeah. We'd invite the secretary to send us proof that you know where those kids are. Ms. McBath, you're recognized.
Thank you so much, Madam Chair. Good afternoon, Secretary Becerra. It's very good to see you. Thank you so much for coming before us today. For more than a year, my bill to cap the cost of insulin at $35 a month has been lowering prescription drug costs for our seniors. This life-saving medication is more affordable for millions thanks to our work here in Congress and your work in the Biden-Harris administration. So thank you once again for that, Mr. Secretary. But I believe we can do a lot more, as we all do in this room. The fact of the matter is that insulin is still too expensive for working families in America, especially for those who have young children. Parents are still waiting in the line at the pharmacy after work or during their lunch break and being forced to pay 20 or 30 times more than what citizens of other developed nations are paying for this life-saving drug. And just, actually, it's just a few dollars for the manufacturers to produce it, but of course, our constituents are paying far more money for this life-saving drug. And I'm just proud to be the lead here on this committee on our efforts to lower the price of insulin for every American in the United States. Mr. Secretary, can you briefly discuss your budget request that ensures that every American has access to insulin at a price point that they and their families can truly afford?
Congresswoman, first, thank you for the work that you did to make it possible for so many Americans to benefit from $35 or less insulin. We, in this budget, we proposed that $35 amount be available to every American, not just to those in the Medicare program. Medicare, 66 million Americans. It's great for the 66 million, but there are 332 million or so Americans in this country. Everyone should have access to reasonably priced insulin and other prescription medication.
Well, thank you. And I'd also like to discuss our efforts to protect survivors of domestic and family violence. The House did pass my bill. I'm really grateful for that. The Bipartisan Family Violence Prevention and Services Improvement Act, as we call it, FIPSA. They passed that last Congress to reauthorize and improve family and domestic violence prevention and support programs. As the only source of federal funding that is actually dedicated to supporting domestic violence programs and the shelters around the country, this program is really a lifeline, truly a lifeline for organizations and for families that they're doing their best to escape this cycle of violence that they find themselves in. Could you please use what time that you actually have left, and you have quite a bit of time, so please expound as much as you can, to talk about the importance of reauthorizing the Family Violence and Prevention Services Act?
Congresswoman, there's no doubt that we are seeing families, children suffer as a result of domestic violence. Because we treat it as a criminal activity, we lose out because we should also treat it as a healthcare crisis, where we need to improve the health of the families that are impacted most by this domestic violence. We are trying to do what we can. In the money that was made available through the bipartisan bill to address gun violence, there were some monies that we invested to address domestic violence, because many times that domestic violence is actuated through the use of weapons. And so what we're trying to do is more immediately reach families before the violence occurs. And that means giving people alternatives. There may be a case, for example, that the individual, a spouse, for example, may not have any other options but to leave. Sometimes they have nowhere to go. If we can increase the options for a safe place for that person to go, we can probably save a life and probably help ensure that the family can start to recover. We are going to do everything we can in this issue of domestic violence, because we consider that type of violence we see in this country as a healthcare crisis that must be addressed immediately, especially because of the mental health concerns that we see for so many of these family members.
Mm-hmm. Well, I just want to thank you so much for all the work that you and the administration do. Is there anything else that we specifically here on the Hill can do to help expedite that very kind of support that you need? Because we know that exponentially a lot of the domestic violence cases are growing, gun violence cases are growing across the country. I think all the empirical data continues to show that, we're in a public health crisis, as you stated. So is there anything specific that you need from us to help do what you need to do to protect Americans?
Treat this as a healthcare crisis, so that way we are able to receive some of the resources to try to address this as a healthcare crisis. And secondly, you mentioned it, data. We need to have good data to see what we can do, where we need to do it, and we need to collect the data and then be able to assess it.
Mm-hmm. Well, thank you so much. I appreciate you, and I yield back the balance of my time.
Thank you, Ms. McBath. Mr. Good, you're recognized for 5 minutes.
Thank you, Madam Chair, and welcome back, Director Becerra. I appreciate you being here, Secretary. Do you think abortion is a good thing?
I think my wife is an OBGYN. I will tell you that
Do you think
oftentimes,
abortion is a good thing?
Congressman, if it's a service that's needed in terms of
Do
providing
you
good
think
health care,
abortion is a good thing?
I think abortion is a service that's essential for
Do
many
you think
women.
abortion is a good thing? That would be a yes or no answer.
I think I've answered your question, but I
You
can
haven't
continue.
answered it. Do you think abortion is a good thing?
I think for many women, it is a
Do you think
resource that they
abortion
need.
is a good thing?
I think for many women,
Okay, so do
healthcare-
you think abortion is something that should be reduced or something that should be expanded?
I think women should have access to the health care
Do you think
services they
abortion
need.
is something that should be reduced or something that should be expanded?
I think women should have access to the
Do
health
you
care
think that
they need.
abortion should be reduced or expanded? Do you think it's something that's a good thing that should be expanded? We ought to have more of it and celebrate that as success? Or do you think it ought to be reduced? It's a bad thing. We ought to do everything we can to reduce abortion.
Do I
What is
think
your view
having-
on that?
do I
That's a
think
pretty
having
simple
access to
thing,
health-
one or two of the directions.
Do I think having access to
which
health
one,
care is a
which
good
one
thing?
do you believe? Should be
If
reduced or expanded?
If the question
good thing,
is,
bad
do I
thing?
think having access to health care is a good thing? Having access to health care is a good thing.
Okay, I didn't ask you about health care. I asked you about abortion.
Abortion is health care.
So killing a child, terminating a child in the womb is health care.
Access to the health care a woman needs.
That would
is
make
important.
sense that that's how you would view it with your policies on it. On May 6, HHS issued a final rule titled Non-Discrimination in Health Programs and Activities that uses Affordable Care Act to advance the radical left, that would be you, agenda to redefine sex by including sexual orientation and gender identity as classes protected from discrimination. But further, the rule also says discrimination on the basis of pregnancy termination can be a form of sex discrimination. Let me read that again. The rule says discrimination on the basis of pregnancy termination can be a form of sex discrimination. Can you explain what this means? I mean, how is pregnancy termination now a class of people that needs to be protected?
Women need access to care. If they need reproductive care and they're denied it, they are now having their rights abridged.
So if we don't provide coverage for the termination of a pregnancy, the killing of a child in the womb, which, by the way, I might add, the #1 killer in America is what? Your Health and Human Services. What's the #1 killer in America?
Why don't you tell me, since you're going to tell me what anyway?
Go ahead. What is the #1 killer in America?
I'll let you tell me. You don't seem to want to
So
have me
heart
answer the question,
disease
so I'll
or
let
cancer,
you answer.
they're numbers 2 and 3. #1 killer in America is abortion. #1 killer in America is abortion. So your rule says that if a woman's health insurance plan isn't giving her the unfettered right to end her child's life, then she can claim she's been discriminated against. That's correct?
The way you described it, no.
Okay, why don't you clarify then?
A woman should have access to the care that she needs. If
So
the
it
care-
would not, let me ask that a different way. So it would not be discrimination to not cover the ability for a woman to kill her child in the womb. For that not to be covered is not discrimination. You're not saying that.
I wouldn't characterize it the way you have, so I can try to answer the question, but I wouldn't answer the question that you've posed, because it's posed inaccurately.
Do you believe that someone who opposes abortion should be accused of discriminating against a woman because they choose not to end the life of a child? Is that discrimination? If you oppose abortion, you oppose the termination of life in the womb, the killing of a child in the womb, that's discrimination?
If a person is being denied the health care that they need, then that requires action to be taken.
So it's bad enough that this regulation applies to Obamacare, but of course you didn't stop there. The rule also states that the HHS Office of Civil Rights will extend non-discrimination enforcement to third-party administrators contracting with group health plans that are self-funded. So this is reaching into a whole new category of private insurance. So now, under your regime, every employer-sponsored health plan would be required to provide gender-affirming procedures. That's an interesting term that you and your colleagues like to use, and abortions. And it could even force medical professionals to violate their expertise if they believe these procedures are wrong or harmful, which they are, or their beliefs on the best care in a plan for individuals, particularly children. Worse yet, your budget proposes a $17 million increase to the Office of Civil Rights so you can weaponize the department against doctors who don't want to provide abortions to women. So the question is, why do you and the rest of the Biden administration, why are you so determined to violate Americans' religious beliefs through abortion and so-called gender reassignment mandates? They are mandates, but why are you so determined to violate Americans' religious beliefs through that?
We're not. We actually protect and are willing to enforce the religious beliefs and conscious protections that are afforded to all Americans.
Well, we don't see that in this rule. There's
should
no need for the
refer you to the
rule.
rule so
And
you could read it.
discrimination, non-discrimination law does not give you or HSS the authority to mandate this nationwide abort and gender reassignment surgeries. And I yield back, Madam Chairman.
Ms. Manning, you're recognized for 5 minutes.
Thank you, Madam Chair. I don't know about you, but I need a breath after that appalling attack on women's health care. So let's take a breath and move on. I'd like to start by responding to some comments made at the top of the hearing regarding the proposed budget. The investment in our young people, in their health and education, is critically important for the future of our country. If we don't ensure that all of our children get a top quality education, including preschool, and the health care they need, we will fail to create future scientists, physicians, nurses, teachers, tech innovators, artists, and business leaders from diverse walks of life who will ensure the future of this great country. So I want to thank you for presenting us with a budget that invests in our future, our children, including universal preschool, which will help all kids get the start they need to achieve. So I'd like to move to another area, and that's an area of crisis in this country, and that's mental health. In your testimony, you state that HHS is transforming the way we deliver behavioral health care. And I am delighted to see that, because I met yesterday with a constituent from one of my major hospital systems, Cone Health, and he raised the urgent need for more options for treating people, especially young people, with mental health problems. And earlier this week, I met with a group of our police officers, and they gave me the same message. We need more options for effectively treating people with mental health problems. Secretary Becerra, you are no doubt aware that the mental health crisis is overwhelming our emergency rooms across this country, which are often forced to keep patients until a bed in a long-term facility opens up. So can you talk about what HHS is doing to relieve the stress on our emergency rooms and find more effective options for treating people with mental health problems?
Congresswoman, thank you for the question. One of the things that we're trying to do is work with states who are the ones who have oversight over the hospitals and mental health services to make it possible for them to expand their mental health services so you don't take up an emergency room bed for someone who really is in need of behavioral health services and isn't there for some physical emergency need. And what we are doing, for example, with many states is offering them a chance to modify the way they use Medicaid dollars so that they can expand access to Medicaid dollars in the behavioral health space. And so some states have taken us up on this opportunity so that they are showing that they can take a person, whether in an emergency room or someone who's homeless, take them off the street, provide them with mental health services, housing, stabilize them, and therefore keep them out of that emergency room in the future. That saves everyone money, including the Medicaid program. And so we're willing to engage with a state that wants to come up with innovative ways to use Medicaid dollars, because if at the end of the day, we're saving Medicaid money by having that person treated more directly by the state, it's a good thing for everyone.
Great, and I hope you'll make sure that CMS has a proper code so that they can get reimbursed for those creative, innovative services, because that's a problem. Also, we're seeing mental health crises in our schools, and I have visited schools across my district that are desperate to have more school psychologists, nurses, social workers to help our young people deal with the mental health crisis. And I have introduced a bipartisan bill to integrate mental health wellness programs and necessary resources into our school wellness programs. Can you tell us how your budget would help address the mental health issues our students are experiencing?
And here again, while the president tries to invest substantial amount of money, as I mentioned, more money for behavioral health than any we've seen in our generation, but more precisely, working, for example, through Medicaid again, trying to get the Medicaid program directly into the schools to provide behavioral health services to children so they don't have to wait till they leave the classroom, leave the school, and then go to a doctor to get the mental health services they need. They can get it right there on campus so that we can start to treat these issues quickly for children. And we can do that without costing a school or the school district dollars that they would otherwise spend for learning, because they're able to draw down Medicaid dollars.
Thank you. I was going to talk about my Right to Contraception Act, which will help defeat the attack on women's right just to even have birth control, but I am out of time, so I want to thank you for your testimony. I yield back.
Thank you.
Thank you, Ms. Manning. Ms. Miller, you're recognized for 5 minutes.
Secretary Becerra, in your final rule titled Non-Discrimination in Health Plans and Activities, you mandate that private health plans provide sex change operations on children and abortions for minors, or risk losing their federal funding. And this rule certainly would violate the religious conscience of thousands of doctors and medical providers. What would your department do if a doctor refused to provide the treatments mandated by this rule?
Congresswoman, first, that was not accurate what you said, and a provider, if they, for religious reasons, object, they are not forced to provide any particular service.
Well, your rule says that gender identity and sexuality is protected under the title Sex Discrimination. It says that a doctor cannot refuse service to a patient for that care, and I actually don't believe you. Your department has a history of violating the closely held religious beliefs of people, and doctors do need to know. Would you tell me today, can you commit here today that your department will not withhold federal funding from hospitals or doctors who refuse to provide the gender-affirming care that you are, mandating if it violates their religious beliefs?
So now, Congresswoman, recognize you're going somewhere completely different. First, you started talking about how a doctor should have the rights to not offer particular care. Then you stretch it out to provide for the system-wide services that are
Yes,
being
you've
supported. Very
put out
different.
this guidance.
Very different.
You've put out this guidance, and doctors do need to know.
Yes.
What are you going to do if they refuse to provide this care?
A doctor, if that doctor has religious objections, that doctor, under these rules, is not required to offer
Okay,
the
so
care.
you're committing here today that you will not withhold federal funding,
Doctors don't get federal funding, ma'am.
but the hospitals do.
Okay, so now talk to me about the
Are you saying that the...
Don't confuse the two.
Okay.
A doctor is not a hospital.
But the doctors are working in these hospitals. Are you going to say today, are you committing that you will not withhold federal funding from those healthcare facilities?
If a healthcare facility is violating the law and not providing the service they're required to,
We
they are
knew
not
that
entitled
you
to the
would
resources.
withdraw federal funding. Mr. Secretary, the United Kingdom recently banned private health providers from performing gender-affirming care on minors. Their decision relied on a study that stated puberty blockers may damage a minor's ability to think and reason, and that the rationale for suppressing puberty at all remains unclear. Mr. Secretary, are you worried that other countries are banning puberty blockers for children, while here in the United States, the number of children on puberty blockers continues to increase each year, as you can see here?
Congresswoman, we rely on the best medical evidence in knowing what services to provide or to support and provide reimbursement for.
Your
Those
department
services-
is marketing these drugs to children. The guidance on your website tells children how great puberty blockers are. And so you're getting what I want to stop people like you that are forcing these non-reversible treatments on children. I'm asking on behalf of parents across the country.
Yeah, and if you would accurately portray what we were doing, it'd be easier to respond to your questions. But you continue to mischaracterize what we said.
I'm not mischaracterizing you or what you're
Read
promoting.
them what
you
we're
have
doing.
put out this
Congresswoman,
guidance.
why don't you
are
read what our
promoting
regulation
the use
says?
of dangerous, toxic chemicals that are not reversible, that are experimental. You are promoting unnecessary surgical mutilation, and it is a fact that 80% of our youth that struggle with gender dysphoria end up growing out of it. And I can say that no rational or compassionate person would be promoting this. Joe Biden and his administration are attempting to force doctors and medical providers to go against their closely held religious beliefs and are forcing toxic experimental drugs on young children. It is a fact. These drugs and procedures have serious side effects and will take away their ability to ever have children. The Biden administration is also distorting the ruling in Bostock to push their far-left political agenda. Justice Gorsuch was clear in his majority opinion that this ruling only applies to Title VII. It does not give Joe Biden license to push radical policies like this rule. History will show how wrong you and Joe Biden are on this issue. Thank you, and I yield back to Dr. Fox.
Thank Mr.
Thank you, Madam Chair. Mr. Secretary, nice to see you as always. Wonderful job. And your work on reducing costs for Americans, I'm somebody who benefits from that. Since being diagnosed with stage 4 leukemia 10 years ago, my medication used to be one of those medications that was $300 to $400 more than the rest of the developed world, in spite of the fact that American taxpayers paid for most of the basic research. So I'm grateful for that. Tell me the consequences. The most recent spending bill appropriations did not fund the 21st Century Cures Act. How does that affect all the good work we've been doing for people like myself who are living longer lives because of their investments as taxpayers in cancer research and deployment?
And Garson, I have to, before I answer the question, just say, you look good, and it's always good to see you, and when you're looking good. So
you should run for office.
No, I just appreciate it because I remember our days when we were together, and it's always great to see that, you know, when fighters come out of this winning. So I'm glad you're standing and fighting. In terms of the question, the delays in reauthorizing critical legislation that lets us continue the discoveries, continue making more readily available and reducing the cost of some of these life-saving medications is just time that we're losing. There's no reason. Everyone knows how the Cures law has helped people like you and others. We should get to the task of reauthorizing it yesterday.
I want to ask you a question about another, something near and dear to me as a survivor of suicide. Your work on suicide prevention. We've had a lot of discussion here about mental health. The CDC's report that almost a third of adolescent girls in this country have seriously considered or attempted suicide. You have an action plan. Can you speak to that?
Yeah, it's, anytime you hear stories that 10-year-olds are contemplating suicide, you have to wonder what's going on in this country. And so we are, because of the president's commitment, we are able to devote more resources to help states try to tackle this. Again, we don't operate the programs directly at the federal level. We're too far removed, but we support the states and the local health departments and mental health departments that provide these services. So what we're doing is we're being more aggressive in trying to get monies directly into some of these mental health programs for young people. I've mentioned how we're trying to get into the schools with behavioral health programs. We're also committing several $100 million in workforce development so we get more of the behavioral health specialists that we need. I mentioned in my opening testimony, this president's budget would make it possible for us to hire 12,000 additional psychiatrists, psychologists, therapists, and so forth.
Yeah, I'd love to work with you more. Madam Chair, you and I have discussed this when we had the gavel and I was chair of the Health Subcommittee. We had good bipartisan talks about this, but since parity, we've had a 300% increase and a reduction on the shame associated with suicide and mental health. But we've had a similar decrease in young people going into the field. So my Mental Health Matters Act, I'd love to work with your department and with the chair to figure out if we can make that, because there seems like a bipartisan consensus that we need to invest more in the deployment of behavioral health and what we've learned about the neuroscience of how we operate. I wanted to ask you a question about the Kaiser Foundation's report on denials of billing requests. I've had comments, a friend I went to college with who owns a primary care practice in Bethesda has bought it from his dad, his brother runs it. He called me and said, we're spending all of our time on these denial of claims. Kaiser says that almost 50% of claims with one insurer has been denied. There's another claim from Kaiser that almost 80%. I've heard this from my providers. My dentist told me this week that they spend all their time, these small firms, just trying to get This came about, according to Kaiser, from actions that the previous administration did to undermine your ability to actually oversee this, and this, the majority party's inability to fund you at a level that we can hold the insurance companies accountable. I really want to work on this. I talked to clerical people in my doctor's office. They said they're spending all this time just trying to work on claims that used to go through that were well substantiated, but you can't provide the oversight to make the insurance companies. The inefficiency of this is outrageous.
Yeah, and what you're pointing out is the difference between, in the Medicare program, for example, what is traditional Medicare, fee-for-service, versus the managed care program called Medicare Advantage. Medicare Advantage, we don't have that site that you're mentioning. We can't dictate, we can't tell them, hey, we hear you're not paying your bills. Providers can bill directly under fee-for-service, traditional Medicare, to a Medicare program, and Medicare pays them directly. But under the managed care program, Medicare Advantage, we don't do that. We pay them, we pay the insurers early, before they even provide a service. Then they get into this hassle of prior authorization and all the rest, and providers have a heck of a time trying to get reimbursed by the insurance companies.
And people give up.
Yeah.
Thank you, Madam Chair.
Thank you. Mr. Burleson, you're recognized for 5 minutes.
Secretary Becerra, according to the Congressional Budget Office, they estimate that the ACA plans cost the taxpayers 3 times as much as an employer-sponsored plan. With that being said, is it beneficial or better that we would encourage more policies to migrate towards an employer-sponsored plan as opposed to the ACA?
Congressman, remember, there's a difference between an employer-sponsored plan, an ACA plan, the Medicare program, Medicaid. All of them are different. The reason that there may be a greater cost in an ACA plan is because these are individuals that don't work for a large employer, can't take advantage of the large pool of employees that would be part of a system. The employer gets discounts because they're bringing a whole bunch of people into the system.
Wouldn't it be great if they get the discount, the taxpayers win, they win?
Yeah.
Is that not a good deal?
It would have been great, but remember, before the Affordable Care Act came into play, all these folks couldn't find insurance because the insurance carriers wouldn't offer them insurance.
Arguably, we had high risk pools, and I don't want to get into that. That's pretty detailed stuff. But wouldn't it be great if we found a way to reduce the employer-sponsored plans by 29%? Then obviously more people could be able to afford to get access to health insurance.
Reducing the cost of health care would be a great thing for
Especially
any
in the
American.
private market, and then it would save the taxpayers even more, right? Because we're no longer paying for them to be on the ACA.
The more people are insured, the less it costs all of us.
So we have the Association Health Plans, which was an innovative idea. They have, a lot of the associations in America have had a longstanding interest in allowing themselves to combine lives to create those larger pools that you're talking about. And in 2018, the Department of Labor issued a final rule to expand access to these associated health plans, which actually did reduce the cost of insurance premiums by 29%. But just recently, the Department of Labor issued a final rule to rescind that 2018 rule. How do you think that that's going to have an impact on the costs and the access of affordable care for patients?
And recognize that the actions that you're speaking about were done by the Department of Labor, not by the Department of Health and Human Services. But what I can tell you about the various types of offerings, health insurance offerings that are out there, what you want to make sure is they all provide a core level of services, the basic level, essential services that anyone would want. Preventative care, for example, maternal health care, natal care. We want to make sure that you're providing the basic services. If you start to go outside of the Medicare program, Medicaid program, employer insurance, or the Affordable Care Act, you start to get into the weeds and the gray areas where these providers of these plans can avoid providing some of those basic services. That's the problem with some of these association-based plans.
No, I absolutely disagree. There's no difference between an associated-based plan. When they go out to bid for pricing,
I guarantee you there are big differences.
There's a difference because they're able to negotiate in bulk. I have a different line of questioning I want to get to before time expires. Last year, you testified before this committee, and I asked about the 85,000 unaccompanied alien children that your department was not able to regain contact with. You made repeated comments that the moment that you were able to place them with the vetted sponsor, you lose custody. But you do attempt to call them, correct?
Yes.
How many have you been able to contact?
Well, I would say that the majority we contact at some point, whether it's the child or the sponsor.
Do you have a number?
I could try to get you a number, because again, they don't have to, they're under no obligation to reach out to us.
You did prep for this, right? Like that last year, that was a course of dialogue questions that you got a lot of questions about. And so I assume that you were.
I prepped for budget questions.
Okay.
Budget questions.
Right. So you would say that this is a concerning, you would agree that it's concerning the number of children that we're not able to identify.
What I'm concerned is that members in Congress continue to ask me if I'm concerned. I would ask you, are you concerned enough to give us authority so we could actually track these kids? Because we don't have authority to track them.
Let
we
me ask
make
this
an
question.
effort,
When
but it's
you're
a voluntary
placing
effort.
these children, do you ascertain whether or not the homes that they're being placed into, that they are able to actually work, that they're eligible to legally work in the United States? Is that one of the questions you ask?
Children should not be working. They should be going to school.
No, I'm asking because why would you place them in a home where no one can provide any kind of support?
You cannot become a sponsor if you indicate that you don't have the wherewithal to support the child.
And that means that they're able to legally work in the United States? Do you verify that?
We make sure that they have the income that would be needed to care for the child. That's
Legally.
part of the vetting process.
Legally.
You know, we are not INS, or we're not the Department of Homeland Security. Our job is to find someone who can care for
Surely
this child.
you could connect with them. My time has expired.
Thank you. Ms. Omar, you're recognized for 5 minutes.
Thank you, Secretary Becerra, for being here with us today. Since DOPS, Republican politicians have been attacking women's reproductive health care and in turn jeopardizing the lives of millions of women. Can you tell us what steps HHS has taken to ensure that women continue to have access to comprehensive reproductive health care, including abortion?
Congresswoman, we've taken a number of steps. Obviously, everything will fall short of what the protections that Roe versus Wade had provided to women. But for example, we have gone all the way to the Supreme Court to protect a woman's access to medication abortion, mifepristone. We have gone all the way to the Supreme Court protecting a woman's right to emergency care services. We are continuing to enforce laws that require providers and insurers to offer contraception services to women. We just issued a rule that would protect the privacy, health information privacy of women and their providers, so that that can't be used against them. I could go on, but I suspect you have more questions.
No, thank you so much for that answer. I'm really concerned about the epidemic of the opioid crisis that we are looking at, that is shattering the lives of thousands of people across Minnesota. My family has lost close and personal friends to this epidemic. In Minnesota, opioid-involved overdose deaths increased 43% from 2020 to 2022. The number of deaths has more than doubled since 2019. Indigenous Minnesotans are dying at over 9 times the rate of white Minnesotans, and Black Minnesotans at over 3 times that rate. And we're seeing a disturbing increase in addiction rates among the East African immigrant population. I'm deeply concerned about these disparities and about ensuring that hard-to-reach communities are receiving the care and services that they need. I see that in the budget, you have requested $1.6 billion for the state opioid response grant and $2 million for the youth prevention and recovery initiatives specifically. Can you tell us what steps the agency is taking to make sure that the federal funding is going towards culturally competent care? And how are you going to serve the underserved populations?
And Congresswoman, we are making every effort to try to encourage states to adopt culturally competent programs so that they can reach populations that are often neglected or underserved. We continue to try to stand up opportunities for them to get funding to increase the number of clinicians and professionals who are coming from communities where there is a shortage of those individuals. We could use more resources to really push the envelope on this. But we are making every effort, for example, to also collect data that gives us a better sight on where there are absences of the professionals that we need. And we're trying to also recruit people, help states recruit people who have lived experience, so that when they go out to be the professional, they've gone through some of those experiences that they're now trying to help people with.
Yeah. And it looks like those impacted are getting younger and younger. I know that there are resources that are focused on education and deterrence. What do you think can be done to better assist folks who are already addicted, as well as the parents, considering that many of those suffering are under the age of consent and need their parents' approval for treatment?
I've mentioned on several occasions already how we are trying to get states to adopt Medicaid innovations that would allow us to use Medicaid dollars in a school to provide behavioral health services in a school, so a child and a family member doesn't have to wait until you find a doctor that you can send your child to help with substance abuse or mental health services. We are hoping, there are about 15 states that have worked with us to change their programs, their Medicaid programs, to accept those dollars. We have several programs, one called Project Aware, that's specifically focused on children to try to help them address issues like drug use, suicide, prevention, and we're trying to expand those services, working with states to see if they'll adopt them.
Yeah. Our kids are really in desperate need, so I hope those services reach them. Thank you so much.
Thank you. Mr. Kiley, you're recognized for 5 minutes.
Mr. Secretary, under federal law, folks who are here illegally in this country aren't eligible for Medicaid benefits, but some states have circumvented this by using state funds to expand eligibility for their Medicaid programs to the entire population of undocumented immigrants. Do you support those initiatives?
Congressman, they haven't circumvented any law. They're just using their own state resources to do what they want for the populations in their
Do you
state.
support those initiatives?
Absolutely.
You do. You support expanding eligibility like your own state of California has at a cost of $3 billion to every person who's in the state illegally.
The state has decided it wants to make sure as many of its people, if not all of them, have access to health care.
So you just said you support that. Is that administration policy or your policy?
You asked me, and I answered as an individual.
Do. Okay. Do you know if the administration has a position on it? Do they agree with you and support that policy?
The administration wouldn't interfere with the state's decision to use its own money.
Sure, but you said you support it. So does the administration support expanding eligibility for Medicaid programs to all undocumented immigrants?
Congressman, as you know, we use federal dollars, and we make sure the federal dollars are used properly. A state can use its state dollars as it wishes.
So you support it personally, but not necessarily the administration?
No, I don't want to speak for the administration because we wouldn't have a position on how a state, your state, my state, uses its own dollars.
Well, I'm sure you do. You would. I mean, there's all kinds of positions the president has about what states are doing, but he hasn't spoken.
Okay, then you can ask the president.
Okay. You started your testimony by talking about COVID, and you said we can now manage it like the flu. Yet there are 30 universities in this country that still have COVID-19 vaccine mandates for students. Do you think it's time they ended those?
They're managing it.
I'm sorry?
We're trying to manage COVID, and everyone can manage it as they see fit.
Well, that's certainly not how the administration conducted its policy during the pandemic. There were all kinds of mandates in various programs. So is there any authority, health authority under your jurisdiction that at this point even recommends universities to have COVID vaccine mandates?
The recommendations principally put out by the CDC show best practices that everyone can employ.
Right, so do they recommend vaccine mandates at universities right now?
The recommendations are pretty clear, and states can then do what they wish.
Is that a yes or no for universities?
It's the states have the ability to do what they believe is best for their
So just right
population.
now, you as the Secretary of Health and Human Services, you have no opinion on whether it's a good thing for these universities to continue their COVID vaccine mandates in May of 2024?
Well, we've expressed what we think is best practice in those policies that have been articulated by the CDC.
Okay, so is it best practice right now for a university to have a vaccine mandate for COVID or not?
Well, the best practices have been set out by CDC. Then any entity, whether it's a university or state, then decides how it wants to move forward.
What's the best practice for a university? Should they have vaccine mandates now, yes or no?
There are thousands of universities. I'm not going to speak for thousands of universities.
Are you familiar with the biolab that was discovered in Reedley, California, that was set up with links to China?
I'm familiar with it.
This was discovered last year or maybe even sooner, and there were all kinds of pathogens there. It was actually set up by an international fugitive named Jesse Zhu, who's currently under federal indictment. Local officials found pathogens like E. coli, hepatitis B, hepatitis C, HIV, malaria, and others. And yet when local officials reached out to the CDC for help, they refused to provide it. This is from a report from the Select Committee on the Chinese Communist Party. It says, based on their initial observation in March 2023, local officials began to reach out to additional federal authorities for assistance. Local officials spent months repeatedly trying to obtain assistance from the CDC, but the CDC refused to speak with them. And on a number of occasions, it was reported by local officials that the CDC hung up on them mid-conversation. So why didn't the CDC come in and try to help when local officials discovered this situation?
I don't think that's an accurate representation of what CDC has done.
They did. You disagree with the committee's report?
I don't think it's an accurate description of what CDC has done.
I see. Did the CDC test the samples they found at the lab?
I'd have to get back to you on what the CDC precisely did.
Because according to the report here, the local officials asked them to test these samples, these dangerous pathogens, and they didn't do so. Does that sound inaccurate to you?
I think you're leaving out a good part of the story.
What part is that?
I'd have to get back to you because I don't have a direct understanding right now. Again, I came to testify on budget, but I can get back to you and let you know what CDC did or didn't do.
Do you have confidence right now that there aren't similar labs with links to the Chinese Communist Party in the United States?
Recognizing that these labs are licensed by the states, the 50 states, and not by the federal government, it'd be difficult for me to answer that question. The states don't work for me.
Well, I mean, but you do have responsibility for public health in this country. And so right now, as the Secretary of Health and Human Services, do you have confidence that there aren't similar illegal biolabs like the one that was discovered in Reedley throughout this country?
I don't know what every state has in its governance rules for the establishment of some of these labs. So if the question is, do I have confidence that all the states are doing the right thing? I'd have to say, probably not.
Thank you. I yield back.
Ms. Hayes, you're recognized for 5 minutes.
Thank you. And thank you, Mr. Secretary, for being here. I want to talk to you a little bit about social determinants of health, which, as you know, are conditions where the environment that people are born in, live in, work in, learn, play, worship, affect their healthcare outcomes. As of January 1st, 2024, the Center for Medicare and Medicaid Services began requiring healthcare organizations to screen for the 5 risk factors, which they determined to be food insecurity, interpersonal safety, housing insecurity, transportation, and utilities. I know that the department has done work in this area, but my concern is states are really unclear as to what this can look like. In California and West Virginia, they've done some of these things, but there really is no clear, I hesitate to use the word roadmap because I know that the department has a roadmap, but it is not clear guidance. And the thing I want to ask you about today is that under the ACA, 85% of premium dollars are directed towards patient care, and then the other 15% are the medical loss ratio formula. The things I just talked about, those social determinants of health, are not included under the patient care section. Can you speak a little bit to how we can change that and start to look at some of those determinants as part of the entire healthcare spectrum?
Absolutely, and thank you for the interest in addressing social determinants of health. By statute, we are either constrained or permitted to do a certain number of things. Social determinants of health, if you look through most statutes, are not included in the provisions of most statutes. So what we're doing is trying to elevate the issue of what can cause bad health or bad health outcomes, which, as you just mentioned, includes social determinants of health. So we are making every effort we can to make sure that anyone who's out there doing healthcare recognizes that if you're not addressing these social determinants of health, you're missing the boat in trying to keep people healthy.
Thank you. I appreciate that. I introduced legislation called the Social Determinants for Moms Act, which really talks about how all of these things as they relate to maternal health, and my legislation was included as part of the Black Maternal Health Momnibus. It asks for the creation of a task force to better address these things in this country. Do you think that the creation of a task force to at least collect data on these things would be a step in the right direction?
Absolutely, although we need to do more because we need to be able to change statutes or regulations to include social determinants of health.
Switching gears here a little bit, I want to talk about the final rule that was issued recently by the Department of Health and Human Services. Can a doctor be investigated criminally or administratively for providing care to me for cancer?
Can you repeat the question?
Is it, let me see how I want to ask this question. I'm trying to get somewhere. Can I be discriminated against for providing care if I had cancer?
For not providing you care?
Yes.
Again, you have to put it in context. Is the person working in a place that holds itself out as providing
As
cancer
a woman,
care?
if I guess I'm trying to get to the point, if I had cancer, if I had heart disease, if I had a mental health condition, if I had osteoporosis, would a doctor be investigated for providing care? Would I be investigated for seeking care? Would I be investigated for obtaining care?
I think I hear where. If they're receiving reimbursement from the federal government, then they would have to offer you the care.
So if I
Unless they have a religious objection.
if I sought abortion care, would I have the right to have that care, or a doctor deny me that care?
You would have the right to have that care if they're seeking reimbursement by a federal department, Medicare or Medicaid, if it's required by law.
Thank you. If it's required by law, thank you. In my last few seconds, I do want to bring up something that I've heard talked about on the other side a lot about the care of unaccompanied minors at the border. I want to remind my colleagues that in the last administration, we had a crisis of understaffing, of children being lost, of us not really knowing, and I want to commend the department for some of the work that they've done to improve these programs. 24/7 caseworkers, increased shelter networks, increased post-release services. My time is running out, but I want to say that unlike the child welfare system, you don't have the ability to monitor children after they leave your custody, even if they are with a vetted sponsor.
That's correct.
So I guess you could follow up and say, what are some legislative fixes that Congress could make to make sure that our connection to these children goes beyond the point where they are turned over to family members or loved ones, so that we can make sure that they are in fact safe and not falling victim to unsavory actors or trafficking or some of the other things that have been brought up in this committee hearing today.
We'll
you so
invite
much.
Secretary to put those suggestions in writing. Ms. Chavez de Remer, you're recognized, and I note you have your father with you today, and we welcome him.
Thank you. Thank you, Madam Chair. Secretary Becerra, the Low-Income Household Water Assistance Program administered through HHS makes a huge difference for low-income households, as you know, assisting with water and wastewater bills. It's really a great example of how government is working for the people. For those who don't know, if the water is about to be cut off due to inability to pay the bill or something far too real, it makes difficult for families, and this program makes sure that that water can stay on. All Oregonians, all Americans for that matter, deserve reliable access to clean water. In fiscal years 21 through 23, Congress provided $1.1 billion for this program, helping over 1.6 million families. Even so, utility costs have been skyrocketing to compensate for the historic underpricing of water services, as well as to pay for the rising costs of infrastructure, aging, deferred maintenance, sporadic trends in customer bases, and even the ever-constant burdens of regulatory compliance. The government needs to act. That's why Congressman Sorensen and I introduced a bill to permanently authorize this program so that safe and reliable water services always reach those who need it most. So, Mr. Secretary, can you speak to some of the highlights of this program's functionality at HHS? And with that, do you foresee HHS continuing to adequately administer this program? Should it be authorized and funded in future years?
Congresswoman, thank you for the question, and congratulations on having your father here. I
Thank
remember
you.
the first time my dad came, he was very proud, so I imagine he's extremely proud. of your accomplishments.
Thank you.
Very important. You and I come from areas where oftentimes there's a ton of water, and then sometimes there's drought. And a lot of
Or
families...
at the same time.
At the same time, yeah. And so we have to, just the way we think of energy, electricity, we have to recognize that water is indispensable. And so we would love to work with Congress to make sure that we have a program in place that can continue to provide families with the resources they need to just basically live.
Great, thank you. I want to move on to another subject that's important. HHS has played a critical role in cannabis reform, and I want to applaud both you and your team for that. Earlier this month, the country took a huge step forward. Thanks to the research your agency conducted, the DEA finally rescheduled cannabis. And in response, the Department of Justice, for the first time in half a century, has said it will treat federal cannabis violations as low-level offenses. As a proud lead of the States 2.0 Act, which would ensure that every state has its right to determine the best approach to cannabis within its borders, this was really good, welcoming news. Federal guidance has always been a nightmare in this space, and it's more important than ever to create a safe and professional environment for one of the fastest growing industries in America. This has proven to be a responsible process, but unlike Oregon's approach, which was to decriminalize all drugs at the same time, was not a good plan. 3 years ago, Oregonians voted for Measure 110. I hope you're familiar with what I'm talking about, because they told Oregonians that it would reduce drug abuse. Instead, drug abuse exploded, and people fighting addiction have been left to fend for themselves. And then thankfully, there was a small fix in the legislature this year that would somewhat repeal and really answer the cries that people were asking. It wasn't the right approach. And unfortunately, law enforcement, healthcare, and homelessness providers, and the homelessness, which is a growing sector in our community, they're really suffering from this addiction. So, Mr. Secretary, as the former Attorney General of California and now head of HHS, what are the lessons do you believe that were learned from Measure 110, if you're familiar? And as the United States is rapidly growing toward classifying cannabis with its possible federal legalization, how can we ensure that Measure 110 won't be a mistake that's made across the country?
Congressman, you said a mouthful, and let me see if because I am aware of the measure. I don't know the details of it. I know that there was actually...
Let me give you the details.
Sure.
We recognize addiction is a serious problem. We know that access to drug treatment is important and a healthcare approach that's fair and reasonable. But that particular legislation means no arrests anymore, only given a citation. For that citation, if you call 1-800-I-NEED help with drug addiction, you can pay, forego your $100 fine. What did that lead to? It led to mass amounts of drugs on the streets, an open market, and we were not helping the people who needed it most. So it didn't work. That being said, Mr. Secretary, our governor didn't do us any good in Salem, and she kept Measure 110 on life support, and I find that unfortunate. But I need you to commit to my office that the Stakes Act and any future legislation will deal with it as you did in other areas and not continue with really the failed process of decriminalization of cannabis in other ways as it followed Measure 110. So I would like your support and connection on that issue.
More than willing to work with you on some of these issues. Remember, the cannabis action has not yet been finalized, but more than willing to work with you. We work based off of evidence, and so whatever we do has to be evidence-based.
Well, thank you. With that, Madam Chair, I yield back.
Thank you. Ms. Leisure Fernandez, you're recognized for 5 minutes.
Thank you so much, Chairwoman Fox and Ranking Member Scott. It's great to see you again, Secretary Becerra, although I must admit it was a lot more fun when we were talking about rural health and there was mariachis, great art, and food trucks. But here we are.
Those food trucks aren't bad.
So for too long, and I know you've addressed it here earlier, the country has suffered from opioid epidemic. In 2022, nearly half of young adults aged 18 to 25 had either a mental illness or substance use disorder. I do not want to see another headline of a promising young person lost to overdose. That's why I'm introducing and I'm working with the committee around my Campus Prevention and Recovery Services for Students Act. Right now, colleges must operate programs to support students struggling with addiction. My bill makes sure those programs are evidence-based and the Department of Education coordinates with SAMHSA. Secretary Becerra, can you tell us why we need to focus on evidence-based programs to address addiction and how SAMHSA can be a key partner to the Department of Education and these schools?
Congressman, thank you for the work you do here, because what we're finding, and we probably have anecdotal evidence in our own homes, that oftentimes young people don't connect the facts with what they're doing, what they're seeing. So they think it may not be a problem if you have 4 or 5 drinks, and that's not going to cause you any issues. Or they may not believe that there may be harm if you're taking particular drugs, even something like marijuana. And so it's important that we have data that shows what the true facts are, so we can present that to our children so they have a better understanding of what might come before them.
Thank you. And working with SAMHSA will be key for us. At the CHC on the Road event, we had extensive discussion on the risk of closures of rural hospitals. Over 30% of all rural hospitals in the country are at risk of closing. In my district alone, Alta Vista Regional closed its labor and delivery unit. Portales, the Roosevelt General Hospital, reduced its staff hours. One bright spot, however, is HRSA's Delta Region Community Health Systems, which provides assistance to strengthen local healthcare systems across the Mississippi Delta region. But HRSA doesn't currently fund similar grants in any Western rural communities. Secretary Becerra, do you think that Western rural states like Nuevo Mexico would benefit from a similar program, and how can we work together to make that happen?
One of the things that the President Biden has done is given us opportunities and resources to focus on rural healthcare systems, because, as you said, they are very stressed. But we could use more support to make that happen. And so you mentioned the Delta Region Community Health Systems Program, which has been very successful. I suspect there are other regions in the country similar in scope that could also benefit. So I'll be more than willing to work with you on something like that.
Okay, we'll look at that. I know it comes down to funding as well. And we need to remember, and people on this committee need to remember, when we want to support some of the positive programs that you've heard on both sides of the dais here, it takes resources. We both grew up in bilingual households and understand the importance of making sure our workforce is culturally and linguistically competent. In my district alone, 34% of households speak a non-English language at home. And we know immigrants get the job done, right? We are vital to our future success as a nation, including adding $7 trillion to the economy in the next 10 years, $7 trillion, and $1 trillion in government revenue, right? We're paying taxes. We are key. Immigrants are key to our success. So we must make sure that we can also serve them in our medical environments, take care of their health care, because they so often take care of us. Can you share with us how IHHS is expanding the number of bilingual physicians?
Congresswoman, thank you for the question. And as a son of immigrants, I can attest to what you just said. And what we are trying to do is make sure that as we expand the network of especially community health centers, that they are able to provide the services that are needed by the populations around them. And so more and more, we're finding that to offer the linguistically and culturally competent care that's required, you really do need to bring in a workforce that can do that immediately. And so we're trying to support those efforts to try to bring in more physicians, more nurses, more healthcare providers who come from communities that are often disadvantaged. And we're also trying to make sure that we support services so that the communication between those communities and the healthcare providers are sufficient, because sometimes if the communication is not sufficient, the wrong information gets passed or insufficient information gets passed, and you could have terrible health outcomes. And so we know that there's a lot of work that we can do.
Thank you very much. Indeed, bilingualism is a superpower, and I want to thank you for that work. My time has expired, and I yield back, Madam Chair.
Thank you, Ms. Leisure-Fernandez. Mr. Bean, you're recognized for 5 minutes.
Thank you very much, Madam Chair. A very good afternoon, Mr. Secretary. Welcome back. I've got my very first question is something that unites us all. How about that? It also unites the American people because we're fired up. We're all fired up against people stealing our money. Medicaid and Medicare fraud. How much? Do we know how much is being stolen before our eyes, Mr. Secretary?
We don't have a precise number, but we know that there are folks who are always gaming the system.
It's a very big number. And how about this? I've got a report from the National Healthcare Anti-Fraud Association. There is such an association that does a little tracking. They say it's 100 billion. Does 100 billion sound about right, or is that just getting started?
You know, I've heard many numbers, but I wouldn't be surprised.
It's a big number. Mr. Secretary, the American people telling me we want our money back, and hopefully that we're going after it. The CNBC just did a little news story where they interviewed crooks that are stealing our money, and the crooks say, it's just so easy. It's unbelievable. I know that the administration is pursuing and persecuting people, some will say that haven't committed crimes at all, but what are we doing to go after bad guys that are stealing our money? Are we putting them in jail? Are we going after them?
We are. We have a team at HHS who does investigations. By the way, we are proposing $4 billion to help us do the investigations of fraud detection. For every dollar we invest, we return about $3 to $5 to the
Do we
taxpayer.
track that? We should
Yes,
put
we
that
do.
on our website. This is how much money we've got back. Now, when you find somebody that's committed fraud, do we kick them out of the program and can we ban them for life? Do you do that, Mr. Secretary?
We try to remove those who have violated the law.
I hope we do, because we want our money back. There's an issue, you know this, the American people who have health insurance and are covered sometimes get surprised by medical billing. They think they either go in for a procedure or have an emergency procedure, and they get multiple bills, yet they had health insurance. Congress 2 years ago passed the No Surprises Act to say enough. The only surprise has been the implementation of your administration that's kind of fumbled the ball, or at least that's what doctors are telling me. They're telling me it's a big surprise that it's not done yet. Is this on your radar screen, Mr. Secretary, to fix this problem?
Absolutely, but everybody saw the new game in town and everybody tried to get in, and only certain ones were eligible, and so that's what caused some of the chaos.
I hope you'll consider that. I'm meeting with doctors, there's anesthesiologists, there's dermatologists, there's everybody in here and saying we can't get relief.
The good thing is the consumers are now out of that food fight.
Let's hope so. Let's hope so, but people aren't getting paid, and it's no fun to work for free, and that's what's happening. Mr. Secretary, Florida, and I represent the free state of Florida, Florida Department of Children and Families just put out a report this week citing disturbing findings, and that is that NGOs, non-governmental organizations operating under the guidance of the Office of Refugee Resettlement under your leadership are placing children in unsafe, unvetted settings, and even worse, are explicitly prohibited from reporting concerns to law enforcement. Are you aware of this report?
Actually, the state of Florida took the initiative to remove the licensing requirement for these care centers, which doesn't make any sense.
Well, it doesn't make any sense that this report's come out that's devastating. I know we've talked about the 85,000 kids that are missing that we can't find, that you've called. I know you're calling to try to locate them, but we're still putting them, according to this report, we're putting them in places that we don't know.
That's not accurate, but I understand what you're trying to say.
10-4, so you're aware of the report. And I know just earlier you talked about if a kid comes to our border and crosses line, and you gave the example, a 15-year-old kid. 15-year-old kid wants a hearing. Then that 15-year-old kid is not sent back home. They're allowed to stay and given a hearing. What if that kid is 12 years old and says, I want a hearing? Would we do that for a 12-year-old?
If an individual crosses the border and says, I'm seeking asylum, by law...
Even 12. Okay, 9, 7. What age do we say, you know what, you belong with your parents? What age? You said a 12-year-old can do it. They can't get a tattoo in America because they're not old enough. But you're saying a 12-year-old can say, I'm leaving my family, and we keep them. So a 7-year-old, would you say a 7-year-old is enough to say, I want a hearing, and you would say, you need to stay. We're not going to put you back with our parents. Is that what you're saying, Mr. Secretary?
It's not what I say, Congressman. It's what you and Congress have said. And by statute, you say that if an individual requests
Mr. Secretary,
asylum,
I just think it's unacceptable as a parent that if
then you'll have
these
to change the
young
law.
kids are coming and we're not only are losing them, but we're not putting them back with the family.
you'll have to
Mr.
change the
Secretary,
law.
thanks for coming out today. And with that, Madam Chair, I yield back time.
Thank you, Mr. Bean. Ms. Houchin, you're recognized for 5 minutes.
Thank you, Madam Chair.
Thank you, Mr. Secretary, for coming before us today. I'm going to pick right up where Mr. Bean left off, because I, too, am a mom who is very, very concerned about the number of kids who've gone missing, unaccompanied minors who've gone missing under your watch. So you've said repeatedly...
Congresswoman, let me repeat
You
again.
said
No child has gone
repeatedly-
missing under our
excuse me,
watch.
it's my
No
time.
child has gone missing under our watch. Just to
There's
correct.
no children have gone missing on your watch?
Under our watch, no child has gone missing.
So you know where all those 85,000 kids are?
Those children that are in our custody, we know
The
where
ones
they
that
are.
are in your custody. Okay, you keep repeating that. So
It's hard for me to
let
track people I don't have
let
custody
me-
over.
This is my time, Mr. Secretary. I'm looking at a report from Axios back in 2021, and this says, this is critical of the Trump administration. Roughly 1 in 3 calls made to release migrant kids and their sponsors went unanswered, raising questions about the government's ability to protect minors after they're released to family members or others in the U.S. Mark Greenberg, who oversaw the unaccompanied minors program during the Obama administration, was briefed on Axios' findings and says that's very dismaying. If large numbers of children and sponsors aren't being reached, that's a very big gap in efforts to help them. So under the Trump administration, Axios reported that there were 1,500 kids that he lost that could not be accounted for. 1,500 kids under the Trump administration. Under your administration, that number is close to 85,000. On March 1st, 2023, the Homeland Security Act of 2022 transferred responsibilities for the care and placement of unaccompanied children from the Commission of the Immigration and Naturalization Service to the Director of the Office of Refugee Resettlement. Who does the Office of Refugee Resettlement, who does that director report to?
Congresswoman, if you
Is
want
that-
us
who
to
does
have
he report
jurisdiction
to?
over these children, you can give us that authority by law. Right now, we don't have the authority
Well, let
to
me
follow
just-
these children, and that's why it
Let
is
me just go
inaccurate to say
on.
that we've
Let me
lost
just
any
go
of them.
on, because
I
I
just
think
wanted to
that's
correct the record
inaccurate. One
because
of
you
the
have
things that you say-
misstated what we
excuse
do
me,
at ORR.
excuse me. This
I
is
just
my-
wanted to
this
correct
is
the
my
record,
time.
Congresswoman.
Please stop
I
filibustering.
understand, Congress. I just
Please
wanted to
stop
correct the
filibustering.
record of what
Madam
you said.
Chair. So, Office of Refugee Resettlement is under the Department of Homeland of HHS. That is your department. Since then, since March 1st of 2003, ORR has cared for thousands of children incorporating, quote, child welfare values. ORR takes into consideration the unique nature of each child's situation and incorporates child welfare principles when making placement, clinical, case management, and release decisions that are in the best interest of the child. Are 85,000 missing children, is that in their best interest?
Again, Congresswoman, you are mischaracterizing what's going on.
I don't believe I am, sir. I worked in child welfare, and what's happening
Then
to
if
these
you think
kids...
85,000 children are missing, why haven't you tried to pass a law to make sure we can find them?
I
If
believe
you're so
that,
concerned...
I believe that what's happening is you're releasing them from your custody. That's what I believe is
No,
happening.
we're
Because
doing
if
what the
they're
law
under
requires,
ORR
ma'am.
authority, then it is
Congresswoman,
your
we're doing what the law-
responsibility to
we're
care
doing-
for those children, and it is your
While they're in our
responsibility to
custody.
watch out for them. It
You don't-
absolutely is.
okay,
Now,
then you don't
let me
recognize
go
and
back
understand the
to-
law. The
let me
law
go
does not
back
give us
to,
the authority to do what
according
you
to
just
the
said,
FBI, more
Congresswoman.
than 98% of all children that go missing in the United States are found. However, less than 1% of all migrant children reported missing to HHS between October 2019 and April of 2023 have been found. This, I'd like to submit for the record, this is from the Center for Public Integrity, a spike in reports of missing and runaway migrant kids. Beginning in 2020 up to 2022, we see, if you can see, a huge spike in the number of reports of missing and runaway migrant children, again, under HHS authority. Only 1%
They are not
of
under
those from work-
HHS authority, ma'am. I keep
without
trying to
objection.
clarify that for you.
Thank you, Madam Chair. So I am extremely frustrated as a mom, as a former child caseworker. Democrats were very critical of Donald Trump and his administration when there were 1,500 kids that fell into this category. Under this administration, there's an unbelievable number of 85,000 missing migrant children. I would encourage the department to not release these kids when they find placement and to keep track of them for their own personal safety. With that, I'd like to yield the remainder of my time to Representative Owens.
Thank you. Thank you so much. I just have to clarify a couple of things. The rules that we talked about earlier says that the gender identity and sexuality is protected under Title VI discrimination. I want to clarify. You mentioned that the doctors are not forced to, they're not punished. What about the institutions that hire these doctors? If the institutions that hire these doctors tied into your federal funds do not adhere to this discrimination that this rule is now tied to, are they defund? Are they taking away funds?
Congressman, I hope you understand the way the
It's a yes or
anti-discrimination
no.
laws work.
I'm
It's not just a
running out of
yes or
time.
no
Is it a
act.
yes or no? Are you punishing the institution?
We're not
that these-
punishing, no.
So there's no punishment for breaking the rule of.
These institutions understand what they're supposed to do if they're going to take federal dollars.
Okay, so you're going to punish. You're taking away the dollars, right?
No, they decide that if they want to take a federal dollar, they must follow
All right,
federal
so
rules.
you're taking away their dollars. They're deciding, but you're putting that out. If they do
Mr.
not,
Owens, we'll
My goodness.
ask the secretary to please respond more thoroughly to the question
Which question is that?
from Mr. Owens. I will make sure that question is clarified. Thank you.
Thank you.
Mr. Moran, you're recognized for 5 minutes.
Thank you, Chairwoman. Secretary Becerra, I want to talk to you about something that I think is very bipartisan. So let's take a deep breath. I know a lot of stuff that we talk about here today is partisan in nature, and frankly, a lot of it we disagree with. But I think there is something we can agree on, and that is we can agree on the protection of children from child abuse, and we can agree that we should not just prevent it, but we should protect those that are in those situations and get them out as soon as possible. Would you agree with that?
I would.
Yeah. Mr. Secretary, the Child Abuse Prevention and Treatment Act, also known as CAPTA, authorizes grants to states to assist communities to prevent child abuse and neglect. Your department is tasked with overseeing the implementation of CAPTA, as you're aware. I believe that, as I mentioned, everybody here should be on the same page with trying to prevent sexual abuse and the exploitation of children. It's awful and it should be stopped. I'm sure you agree with that, as you said, correct?
As I say, no child should be abused.
That's right. I'm sure you're also aware that a high percent of abusers are actually connected either by family or close friendships to those that they abuse. Are you aware of that as well?
I think you're accurate.
Yeah. The numbers that we see across the board is about 90% of those that are being abused by those that are closest to them, and that's just so despicable. In Texas, the average child spends about 7 hours a day in their school system. That means that most students are spending a good portion of their day, sometimes more with teachers and with staff and school personnel than they are with their family members at home. And that provides an opportunity for them to cry out when necessary. And that also provides an opportunity for those teachers and staff to recognize those students that are being abused throughout the day and then to help step in that moment. Would you also agree with that?
You said a lot. For the most part, I do believe that we have to make sure that we're providing ways for children to communicate that they're being abused or to be able to spot the abuse.
Yeah. In fact, school personnel are critical in helping to identify child abuse cases. I think they account for about 52% of all identified child abuse cases that are actually reported. With that in mind, I strongly believe that lots of child sexual abuse can be prevented or stopped through our educational institutions with enhanced prevention policies and enhanced opportunities for guidance in that area. Do you believe it's important for teachers, school employees, and other caregivers who work with children to be educated about the signs of children being sexually abused?
I know in some areas of the country they do receive some training, but certainly I think the more that our teachers and those who have who are surrounded by children most of the time should have some training.
Yeah, I agree. Do you think additional resources for teachers, school employees, and other caregivers would be helpful in these efforts for them to be able to identify and report so that we can combat sexual abuse?
I think most teachers would say that that would be a good thing to provide the resources for them to be trained and have the resources to implement.
I completely agree with you. In fact, Representative Wild, who's a Democrat from Pennsylvania, and I are working on this exact issue. I've reintroduced what's called the Jenna Quinn Law of 2024, named after Jenna Quinn, a sexual abuse survivor from Texas. This bill would allow HHS to use existing federal funds to be used for eligible entities for increasing evidence-based or information training on sexual abuse prevention. It does exactly what you and I just agreed needs to actually happen is we need to open up additional resources, no additional cost to taxpayers, but more resources here where schools and institutions can tap into these existing resources and get education and training for their teachers so they can report these sexual abuses. Data has shown that after this law passed in Texas, and it's passed in a lot of states, educators reported abuse at almost 4 times the rate than before. Sounds like good progress in my state. Nearly every committee member on this committee in their own home state has enacted a version of this law, that their states have enacted that version. I think it's time that we have a national strategy to stop child sexual abuse, and I think the Jenna Quinn Law of 2024 would be a good way to do it. Hope you'll take a look at it. With that, I'm going to reserve and yield the remainder of my time to the gentleman from Utah, Mr. Owen.
Okay, thank you so much. I just wanted to tie down that last question I had for you. Are you saying then we're not going to punish the doctors that have religious freedom to say no to these operations? Is there any consequence to the institutions that are hiring these doctors? Yes or no?
Congressman, if you understand the way this works, an institution is seeking federal reimbursement dollars.
So that federal reimbursement will end if they do not.
Well, they accept the reimbursement dollars under certain conditions. They have to follow the rules of federal law.
And those rules will be their employees have to make sure they do these operations.
No, they have to make sure they're offering services. If they hold themselves out to be
let me just say this. Let me just finish up. I've taken a lot of time, but this one question, I think is very stealth the way you guys are approaching this. You're not hurting the doctor, but you're hurting their employee, and that's what it comes to. You're taking away their funds.
No,
either way, the result is the same.
Congressman, it's been very direct, and again, people have conscious rights, religious rights.
But you're punishing the institution. I yield back. I think anyway. I yield back.
Mr. Scott, you're recognized for 5 minutes.
Thank you, and welcome again, Mr. Secretary. Mr. Secretary, you've had a lot of questions about problems at the border. A lot of complaints. Are you familiar with the legislation negotiated by Senator Lankford from Oklahoma?
Generally familiar with it, yes.
And that would have solved a lot of problems. What happened to that bill?
Well, my understanding is that the Republican leadership in the House said that it would not put it up for a vote, and the Republicans in the Senate, after the negotiations by a Republican senator, decided to bury it as well.
So that they could continue to complain rather than actually do something. Is that right?
And it would have addressed many of the issues that many of these members have raised.
Thank you. The nursing home rule, have you found any correlation between staffing and deaths in nursing homes, not just anecdotal, but on a statistical basis, where there's a correlation between staffing and deaths in the nursing home?
Substantial.
Okay. You mentioned, and I think you got cut off, how life was before the Affordable Care Act.
Yeah.
People with pre-existing conditions couldn't get insurance. Insurance rates were skyrocketing every year. Millions of people were losing their insurance every year. The benefits they could sell didn't have any essential benefits. We now have the lowest proportion of America lowest uninsured. Do you have proposals to make it even better, to lower the number of people uninsured?
Absolutely.
Particularly in states without Medicaid expansion?
That's right. 1.7 million Americans would have access. North Carolina just recently, last year, expanded Medicaid. More than 600,000 of their population have qualified. They're almost at that number who have actually signed up now to get health care. It's a remarkable thing when you can so quickly give people access to good quality care.
Thank you.
By the way, they also got a bonus check for $1.6 billion for expanding Medicaid.
Thank you. Now, you mentioned mental health, the historic investments in mental health. Is that in addition to the fact that we now have mental health parity, so insurance policy, private insurance covers mental health, and more people have insurance, particularly under the Affordable Care Act and Medicaid expansion? Are those investments in addition to those?
In addition, although I think you recognize, Congressman, that most insurers are still not fully implementing the law that requires parity in treatment of mental health the way we treat physical health.
And are you trying to enforce that mental health parity?
We are trying to make it clear that that is the law.
Head Start is under the jurisdiction of Health and Human Services, not education. What services are provided to Head Start in the Head Start program that make it more appropriate for Health and Human Services than education to be the appropriate department?
So we provide a full spectrum of care within the Head Start program. So it's not just the educational service, because you're talking about children who are under the age of 5. What we're trying to do, and we have a proposed rule that's out there, that would try to make sure that every slot that's made available for each state for a Head Start child is used, because we have too many slots that are not being used. We're also trying to make sure that we professionalize the health of the Head Start workforce, because too many of the teachers in Head Start are being paid less than what you can make going to flip burgers in a fast food joint.
Do the services like vaccinations and things like that, do those extra services that you provide that would not be provided in education, do those services make a difference?
Absolutely. All those additional services make a difference.
Childcare is a challenging problem for all families. The Child Care and Development Block Grant provides child care services for low-income families. Do all that qualify, can they get child care assistance?
It's tough. The president's budget would make available child care services to 16 million of our children who are lower income. It would provide them, their families, with access to care where for about $10 a day they'd get access to care, which probably saves them, by the time the year is up, more than $7,000 on what the average cost of child care would cost most families.
What have you done in 504 Rehabilitation Act to help those with disabilities?
For the first time in about 50 years, we have updated Section 504, which is so important to Americans with disabilities, because it lets them be treated the way they should be, as Americans, not as second-class Americans. So a doctor can't make a judgment that because you're disabled, they don't need to offer you some of the services they might offer to an able-bodied American. And so it's going to be game-changing for many Americans who for the longest time found themselves being treated as second class or put at the end of the line because of their disability.
Thank you, Madam Chair.
Thank you, Mr. Scott. Thank you, Mr. Becerra, for being here today. Without objection, there being no further business, the committee stands adjourned. There you go. All right. Thanks, CJ. Okay, we got her done. Yeah. One step at a time.